Good evening. Today we bring another edition of Ahuja Bajaj Symposium. We always take care to include the most innovative topics and best speakers. Just a bit of introduction of National Diabetes, Obesity and Cholesterol Foundation and also Fortis C-DOC Hospital for Diabetes and Allied Sciences. National Diabetes, Obesity and Cholesterol Foundation was established in 2014 and the purpose was primarily research and education. Since then, we have published close to 150 papers. In 2020 and 21, we have published more than 70 papers in national and international journals and have become fortunate to become a leader in COVID-19 and diabetes, having published many commentaries as well as original research papers. This is our highest output so far. We have plenty of research projects, 2 internationally funded and 2 funded by ICMR, and 7 more research projects being carried out at Fortis C-DOC Hospital. And the flagship project is a major project on diabetes in underprivileged women using customized mobile van. I'll show you a picture in the next slide. And we are co-producing the journal along with Diabetes India. The journal is Diabetes and Metabolic Syndrome, Clinical Research and Reviews. This is a journal which has jumped from the site score of 4.7 in 2019 to now 8.7, the number one amongst all the journals in India at this point of time. And during COVID-19, the citations were third after the Lancet and New England Journal of Medicine. We have been impressed also because of our research, and you can see this is one of the research projects which is done by one of my associates, and in which we showed high prevalence of post-COVID-19 fatigue in patients with type 2 diabetes. And when this was open, this was carried on by 119 newspapers and news websites. So we are fortunate to have good coverage of our innovative research project. This is the only project of its kind in the world. If you see, this is our flagship project. The customized mobile van is at the background. This contains all the facilities for checking the feet, fundus, neuropathy, ankle brachial index, everything in one van. And this goes to the underprivileged areas, and we not only do the screening, but also management of diabetic patients, currently focusing on women. And we have covered more than 2 lakh population with this project, and this population is now doing well. And in one of the articles, you can see this article published earlier, we have shown that with our education and intervention, these underprivileged population has lost weight, and possibly that has led to prevention of diabetes. And my colleagues Ritesh Gupta and Amrita Ghosh, and you will see other colleagues during the lectures. They work at the Fortis C-DOC Hospital in Chirag Enclave, as well as Fortis C-DOC Center at Fortis Vasant Kunj and Fortis Gurgaon. This is a unique hospital because it's one of the first specialized centers for diabetes in whole of North India, but currently also doing number of surgeries, including bariatric surgeries. We have a very good ICU, as well as we have the dialysis center, all investigation facilities, and we have won 5 awards, CIMS awards from 2014 to 2019. There's some kind of record. So with that introduction, I welcome you once again. Thank you for being us. Now I'll hand over to Dr. Amrita Ghosh to make a few announcements before we begin with our academic session. Thank you.
Thank you so much, sir. And I welcome you all for this 8th edition of Ahuja Bajaj Symposium. Very good evening. And I would want to set few house rules first for you. We will be having a scientific quiz today and tomorrow. Today's quiz will be at 8 p.m. We'll be having three winners for today's quiz, and the winners will get cash prizes. I would request all of you to visit the exhibition area, the virtual exhibition area, and visit all the stalls. The stalls have one representative at that stall. So if you want, you can interact with that person through WhatsApp calling. Uh, all those attendees who are interested to get a free copy of Diabetes with the Light written by Dr. Anup Mishra, please email on KOELDUTTAC @ gmail.com, which is koeldattac @ gmail.com. And all the lectures are will be timed at 15 minutes. So the speakers will finish by 12 minutes, 12 to 13 minutes, and we'll be having 2 minutes for your question. For your questions, please, there's a link down where you can ask your questions. Please write down your questions so we'll get those questions. And for the quiz, make sure when you see in your laptop or your phone, there's a small icon of bulb. So please press that icon. You can register yourself by entering your name and your mobile number so that you are registered for the quiz whenever the quiz happens. So before I start this, I would like to invite Dr. Tapan Ghosh for for his talk on when, how, and why of SGLT2 inhibitor in cardiovascular medicine. Dr. Tapan is Director and Head of Department of Cardiology and Head of Department of Clinical Research at Fortis Hospital, Basant Kunj. I welcome you, sir.
Thank you. Thank you for the introduction. Let me share my slide. At the outset, I thank Dr. Mishra and all of you for giving me the opportunity to share my thought. And as you know, SGLT2 inhibition has revolutionized the management not only of diabetes, of cardiovascular medicine. And whenever I talk about SGLT2 inhibition, two things comes to my mind. Number one, an apple a day keeps a doctor away. And this medicine, is originally, gliflozins are originally from apple bark tree, and this satisfied this. And the second one is we have really hijacked a drug which actually was meant for primarily diabetes. So both the cardiology and nephrology team has hijacked diabetes drug. That's two things always comes to my mind. Now, in keeping with the ethos of this 8th symposium, Ahuja Bajaj Symposium, that we should review all the recent advances. And this is one of the most recent advanced definition of heart failure, universal definition of heart failure, symptoms and or signs of heart failure caused by a structural and or functional cardiac abnormality. So you may have sign or symptoms, you may have a structural abnormality or even a functional abnormality, and corroborated by either elevated natriuretic peptide or objective evidence of cardiogenic or systemic congestion. Just to give, if you have just the breathing difficulty, one chest X-ray showing severe pulmonary venous hypertension is good enough for the diagnosis of heart failure. Now, how is the heart failure different in our population? Our population has higher risk of both coronary artery disease and heart failure as compared to other population like Europeans. And this is the hazard ratios: 2.3 for coronary artery disease and 1.83 for heart failure. So we are at higher risk of both coronary artery disease and heart failure as compared to Europeans. This is not for atrial fibrillation. For atrial fibrillation, they have higher risk. This is again contextualizing and conceptualizing the gravity of the situation. Well, we talk about coronary artery disease. High risk means more than 5%, or very high risk is around 10% incidence. But here in heart failure, the baseline incidence is around 10%. Say warm and moist heart failure, classical heart failure patients, they walk into your chamber with mild pedal edema, they're already at higher risk. They have a risk of 10%. And once they are eligible to be hospitalized for some worsening symptoms, the risk goes high. Obviously, we are dealing with a population which has a higher attrition rate, the mortality rate. Baseline mortality is 10%. So this area is a very, very important and exciting area. Whatever we do is not enough. We must do enough for this population because the risk is quite high. Now, we have a large study called EMPA-REG outcome trial. This trial randomized patients with empagliflozin versus placebo. And you can see that it reduced the death and worsening heart failure by 38%. And this is a very, very hard endpoint. In Asian subgroup, if you look into this, it is much more beneficial. 40 relative risk was 0.44, hazard ratio was 0.44. So it is more beneficial in our population as compared to the whole cohort. Now, if you look into the death due to worsening heart failure, cardiogenic shock, that also was reduced from 2.6% in the placebo arm to 1.4%. So the mode of dying also is reduced. Severe heart failure, sudden death, which everything is reduced. Now, how does it do? It addresses the basic mechanism of heart failure. It reduces the preload, reduces the afterload. It improves the diastolic function and diastolic structure of the heart. How does it reduce the preload? It causes natriuresis, diuresis, causes glycosuria, and it reduces intragranular pressure. Thereby, it reduces preload, and it causes a lot of metabolic effects in heart muscle, increased metabolic efficiency, oxygen supply is reduced, oxidative stress is reduced, fibrosis is reduced, epicardial fat is reduced, there is new hormonal stimulation, there is reduction. So all these modulate the diastolic properties of the heart. As a result, the function of the heart improves. It also improves the endothelial function, arterial stiffness is reduced, vascular resistance reduced, all translate into myocardial performance improvement. Now coming to a very elegant study, emperor-reduced study, where patients with diabetes or without diabetes with EGFR more than 20 with heart failure and chronic heart failure with reduced ejection fraction are randomized. And these patients have to be on conventional therapy. The comparator was placebo versus empagliflozin 10 milligram. Primary endpoint was death from any cause and heart failure hospitalization combined. And these are the secondary endpoint. So when you talk about heart failure, we always talk about heart failure, hospitalization, and death. And it is seen that there is a 25% relative reduction of death and hospitalization with empagliflozin, and absolute reduction of 5.2%, which number needed to be treated 19. That means you have to treat 19 patients to get the reduction of one event. Very, very significant in terms of the NNT. Lower the NNT value, higher is the benefit. Now let's look into different subgroups. Whether patient is diabetic, non-diabetic, age less than 65, more than 65, baseline mineralocorticoid use or no use, baseline angiotensin receptor and neprilysin inhibitor ARNI use. This is the forest plot. Anything on the left side of the unity, it favors empagliflozin. Anything favor on the right side favors the placebo. All these subgroup analyses are significantly better and showing that empagliflozin benefits the population irrespective of their diabetes, status, age, usage of ARNI and mineralocorticoid antagonist. Now let's look how early is the benefit. This is the timeline, and it is seen that at day 12, you get the separation of the carbs significantly with a p-value of 0.029. That means if you have treated 19 patients for 12 days, you have really done the job. So this is one of the wonder drugs so far as a heart failure with reduced ejection fraction is concerned. Now let's look into preserved ejection fraction heart failure. That means a person is having heart failure, but the ejection fraction is more than 40%. Now, what is the benefit in this population? That's we are going to examine. Now, just passing remark. Till date, there is no agent which is significantly reduce the endpoints in, diastolic heart failure or heart failure with preserved ejection fraction. Although we know the mortality 5-year outcome is equal in both systolic heart failure and diastolic heart failure. And if you look into the total mortality and financial burden, it is much more than even cancer mortality. Heart failure mortality and financial burden is more than cancer mortality. So anything done to this population will have a significant social impact. Now, look that in this trial, the empagliflozin was given versus placebo, and the composite primary endpoint was first event of death and heart failure, adjudicated event. Now, again, in this population, there's 21% relative reduction of the endpoint, absolute reduction of 3.3. This is an enormous benefit. You have to treat only 31 patients to get one reduction. So number needed to be treated 31. That means this drug, when given to patients with heart failure who has a preserved ejection fraction, there is benefit. Now, one area, mid-range ejection fraction between 41 to 49. This is called mid-range ejection fraction. This is newly named as moderately reduced ejection fraction. MR remains same. We write as MR, but the MR earlier we used to call it mid-range. Now we call it moderately reduced ejection fraction. Till date, these group of patients were not really addressed in a different trial or analysis, subset analysis. Now, this is the data from the same Emperor preserved study group, and it showed that even in moderately reduced ejection fraction, there is significant benefit. P-value of 0.05, 10% versus 7.2%. AMPA reduces the event rate, and first hospitalization also is reduced. So both CV death and hospitalization combined, and CV death hospitalization for heart failure separately are significantly reduced in this group. Now, let's do a subgroup analysis with the gender, baseline diabetes, baseline EGFR, more than 60, less than 60, history of atrial fibrillation or flutter. Does it really matter? So it really does not matter. This drug benefits all these subgroup of patients. So irrespective of these status of CKD, AF, patient with heart failure, with the reduced ejection fraction, more than 40% ejection fraction, whether they're in sinus rhythm or atrial fibrillation, they are benefited. Now, let's look into renal endpoint. We know that kidney and heart are intimately related, and diabetes affects both the diseases, both the organs, and renal disease independently, associated with higher CV events, CV death, and stroke. So anything which alters the kidney function has a significant impact on total death. So let's look into end-stage kidney disease or sustained profound reduction in the EGFR. So empagliflozin could preserve the renal endpoint with the relative reduction with 50%, absolute reduction 1.5%. So it preserved the kidney function. Now, one point is that hypoglycemia. We are very much interested to know the hypoglycemic events. As you are aware that hypoglycemia predicts CV mortality. CV outcome is dictated by hypoglycemic events. Higher the hypoglycemic events for any therapy, it increases the CV mortality. Now, in a patient with no diabetes, the confirmed hypoglycemic events was 0.3 versus 0.3. That means if the patient didn't have diabetes, their hypoglycemia with empagliflozin is only 0.3%. And genital tract infection is not very high, it's 1.4 versus 0.9%. But if the patient is having diabetes, there is 2.4 versus 2.2%, again, not significantly different. The genital tract infection was 1.9%, slightly higher than the non-diabetics, but it is manageable. We know that SG2, LT2 inhibition means that we are working on a glucose transporter, and glucose transporter means it will have an obligatory effect on fluid loss. Water will be lost. As the water is lost, water soluble solids will be lost. So reduction and disturbance in the ions are always a problem and always a serious concern. Suppose we look into different ions like potassium, magnesium, uric acid, calcium. Nothing is really significantly altered by SGLT2 as compared to loop diuretics, thiazide diuretics, acetazolamide, and mineralocorticoid antagonist. So this drug is quite safe. Now, many times we get a question: a patient is already on ARNI, is in heart failure. Is SGLT2 is beneficial on the top of ARNI? The answer is yes. The data shows that if the patient is receiving both the agents, there is added benefit, and there is no concern so far as the potassium is concerned, hypotension and renal dysfunction is concerned. So it does not adversely affect the outcome. It is rather beneficial if you can combine. Now, hyperkalemia. This is always a concern in patients with heart failure. But if you use, ARNI, you give empagliflozin, the incidence of hyperkalemia is reduced as compared to placebo. And mineralocorticoid discontinuation, which is one of the very important parameters in heart failure, because we know that MRA reduces mortality in heart failure. So we are always concerned if we have to really discontinue the MRA in heart failure. But if the patient already is on SGLT2 inhibitor, then the hyperkalemia is reduced, and as a result, the MRA discontinuation is less.
Dr. Tapan, 3 minutes to go.
Yeah, I'm just, I think coming to the end. Discontinuing MRA therapy, again, it is, less that you discontinue MRA in this subgroup. So what are the advantages? Single dose, once daily, no titration is reduced. And summarizing the, SGLT2 inhibition is a fundamental role. It is safe drugs, good for the kidney, early benefit, consistent benefit, and ease of use. So European Society of Cardiology ad hoc task force gives a position statement: heart failure in individual with heart failure with reduced ejection fraction, with or without diabetes, it should be used. In individual with type 2 diabetes, recently hospitalized for heart failure, it should be they should be given given the drug. Type 2 diabetes with high risk, again they should get the drug. You can use either of these, AMPA, CANA, and DAPA. Chronic kidney disease, you can use CANA, DAPA, sotagliflozin, and out of all these drugs, empagliflozin has shown consistent benefit in all these. And the first line therapy in reduced ejection fraction heart failure is a beta blocker, SGLT2 inhibitor, ACE inhibitor, or ARB or ARNI. ARNI is always preferred, and MRA. And if you look into tailored heart therapy, different groups, in all the subgroups, in all associated illness, SGLT2 inhibition is indicated. And this is one of the ways we should give the drug. This is called rapid sequencing. In step 1, we give beta blocker and SGLT2. Step 2, add ARNI, and step 3, add mineralocorticoid antagonist. It should be done very quickly within 4 weeks. Earlier, we used to give within 6 months. So rapid sequencing. So all-cause mortality is reduced. Heart failure is reduced. This is one of the very important. 2 weeks back, this trial was presented at the AHA meeting, and this is a missing link, because we had always had a question that SGLT2 inhibition is good in chronic heart failure, not in acute heart failure. This addresses this trial. Impulse addresses this question. This is a missing thread which comes to us. And it has been proven that in even acute heart failure, once you have stabilized the patient, you give the drug, there is benefit. So this is the 2021 update on is on consensus pathway that all patients with SGLT2 inhibition should be given with heart failure reduced ejection fraction with or without diabetes. Anyway, it's a class 2 to class 4 heart failure. Earlier we used to give class 3 heart failure because class 4 heart failure we didn't have data. This is the data we have now from AMPLE study administered in conjunction with a background.
Please wrap up.
Yeah, drug. So summarizing, why SGLT2? It proven benefit, early onset of CV risk reduction, lesser risk of concern, monitoring therapies, synergistic effect. How does it work? It is salutary effect on pathological pathways of heart failure, both volume and pressure offloading. When to use as soon as possible in these patients. Only concern is EGFR less than 20. All other patients should receive this drug. Thank you very much for your kind attention.
Thank you, Dr. Tapan, for this explicit talk. Sir, because of we want to be on time, so we are moving on. So for the next lecture, I would want to call Dr. Pankaj Agarwal. Dr. Pankaj Agarwal will speak on simplifying insulin delivery, second generation basal insulin. Dr. Agarwal is consultant endocrinologist, hormone care and research center, Ghaziabad. He's been a principal investigator and he has many studies which are quoted nationally, internationally. Over to you, sir.
धन्यवाद डॉक्टर अमृता, धन्यवाद डॉक्टर अनूप मिश्रा, डॉक्टर रितेश इस कार्यक्रम में मुझे बुलाने के लिए। अगले कुछ मिनटों में हम लोग एक बहुत ही यूजफुल टॉपिक को डिस्कस करेंगे, इंसुलिन डिलीवरी में सेकेंड जनरेशन इंसुलिन, और इसको हम एक अलग रूप में प्रस्तुत करना चाहेंगे अपनी मातृभाषा हिंदी में। ये हमारा एक मिशन है, मेडिकल कंसेप्ट्स इन हिंदी MCH, जिसमें हमारा ये प्रयास है, एक प्रयोग है कि हम अपनी मॉडर्न मेडिकल साइंस को किस प्रकार से अपनी मातृभाषा में ला सकें और इसमें डिस्कस कर सकें। मुझे आशा है कि आप इसको पसंद करेंगे। तो मित्रों, बेसल इंसुलिन का इवोल्यूशन ये एक बहुत ही रोचक घटना है, बहुत रोमांचक घटना है। जब से इंसुलिन की डिस्कवरी हुई, इंसुलिन डिस्कवर हुई थी अपने रेगुलर इंसुलिन के रूप में, जो कि एक शॉर्ट एक्टिंग इंसुलिन थी, लेकिन हम जानते हैं उसको देने में हमें मल्टीपल इंजेक्शंस देने पड़ते थे। इसलिए हमेशा यह प्रयास होता रहा कि किस प्रकार से हम इसके ड्यूरेशन ऑफ एक्शन को बढ़ा सकें। तो सर्वप्रथम 46 में, आज से 100 वर्ष पूर्व हमारी इंसुलिन डिस्कवर हुई थी। 1946 में फर्स्ट टाइम इंटरमीडिएट एक्टिंग इंसुलिन NPH डिस्कवर हुई, और उसके बाद काफी समय लगा एक लॉन्ग एक्टिंग इंसुलिन लाने में, और आज हमारे पास एक वैरायटी ऑफ लॉन्ग एक्टिंग इंसुलिन हैं जिन्हें हम बेसल इंसुलिन कहते हैं। और देखिए ये सभी इंसुलिन यदि हम देखें तो ये सब अपनी फार्माकोकाइनेटिक्स और फार्माकोडायनेमिक्स में एक दूसरे से डिफरेंट है। वह किस प्रकार से कार्य करती हैं ये हमको इनके कर्व से, इनकी फार्माकोकाइनेटिक प्रोफाइल से बेहतर रूप से समझ में आ सकता है। सर्वप्रथम डिस्कवर हुई रेगुलर इंसुलिन, जो कि 6 से 8 घंटा काम करती थी, लेकिन एक सिग्निफिकेंट पीक थी और हमको कई बार दिन में देना पड़ता था, तब हम अपने पेशेंट को कंट्रोल कर पाते थे। एक मेजर ब्रेक थ्रू था NPH की डिस्कवरी, जिससे हम बीच के जो फ्लक्चुएशंस हैं, इनके लेबिलिटी है जो रेगुलर इंसुलिन की, उसको फिल कर सके NPH से। तो NPH देने से जो हमारी लेबिलिटी थी, वैक्सिंग एंड वीनिंग रिस्पॉन्स था, वो थोड़ा स्मूथ हो गया। तो 3-4 इंजेक्शंस डेली से हम 2 इंजेक्शंस या 3 इंजेक्शंस पर डे पे आ गए। लेकिन NPH के साथ भी उस वक्त तो बहुत अच्छी लगी, क्योंकि एक बहुत मेजर ब्रेक थ्रू था। लेकिन हमने देखा कि एक सिग्निफिकेंट पीक है NPH में, लाइक रेगुलर इंसुलिन, जो कि रात में जब ये पीक होती है तो मिडनाइट हाइपोग्लाइसीमिया का बहुत रिस्क बढ़ जाता है। तो एक प्रयास चलता रहा कि किस प्रकार से हम इस मिडनाइट हाइपोग्लाइसीमिया के रिस्क को घटा सकें। और इस कड़ी में फिर अगली जो इंसुलिन जो जुड़ी, डेटिमिर और ग्लार्जिन, जो लगभग 20-21 या 22-23-24 घंटे तक काम करती हैं, और NPH के मुकाबले इनकी पीकिंग इफेक्ट कम है। जब पीक कम होगी तो उससे मिडनाइट हाइपोग्लाइसीमिया या किसी प्रकार के हाइपोग्लाइसीमिया की संभावना और कम हो गई। NPH जो हमें दिन में 2 बार देना पड़ता था, अब वो 1 बार इंसुलिन देने में काम चल गया। तो इस प्रकार से एक बेहतर इंसुलिन सिद्ध हुई NPH से, लेकिन पीक तो अभी भी है, और ये पीक एक हाइपोग्लाइसीमिया का कारण बन सकती है। तो इस पीक को और कम करने के प्रयास में ही हमारी जनरेशन 2 बेसल इंसुलिन डिस्कवर हुई। ग्लार्जिन U100 जो पहले थी, basal insulin of glargine U300, a concentrated variety of glargine. डेटमिर जो 16 to 20 आवर्स काम करती थी, जिसमें इंसुलिन के साथ एक लॉन्ग चेन फैटी एसिड्स जोड़ी गई थी, उसी को और मॉडिफाई करके डिग्लूडेट बनी जो लगभग 40 आवर्स तक काम करती थी, और ये दोनों इंसुलिन लगभग पीकलेस इंसुलिन के रूप में डिस्कवर हुई जो 24 आवर्स से भी ज्यादा अपना असर रख सके। तो इस प्रकार से हमने क्या देखा कि पिछले 100 वर्षों में हम शॉर्ट एक्टिंग इंसुलिन पे तो हम प्रयास करते गए कि वो और अच्छी पीक हो, अल्ट्रा शॉर्ट एक्टिंग हो जाए, जल्दी काम करें, शॉर्टर एक्टिंग हो, जिससे फिजियोलॉजिकल इंसुलिन रिलीज के कंपेरेबल बन सके। ऑन द अदर हैंड जो हमारी लॉन्ग एक्टिंग इंटरमीडिएट एक्टिंग इंसुलिन है, इसको हमने लॉन्ग एक्टिंग बनाना चाहा और फिर अल्ट्रा लॉन्ग एक्टिंग बनाना चाहा, जिससे उनकी पीकिंग इफेक्ट कम होती जाए और करस्पॉन्डिंग हाइपोग्लाइसीमिया की संभावना कम हो सके। और इस प्रकार ही किस प्रकार से जो हमने इंटरमीडिएट से जनरेशन 1 और जनरेशन 1 से जनरेशन 2 ये इंसुलिन का जो सफर तय किया, अब हमको यही देखना समझना है क्या यह हमारे लिए और हमारे पेशेंट्स के लिए लाभप्रद रहा। तो आइए कंपेयर करते हैं जनरेशन 2 बेसल इंसुलिन से, जो हमारी प्रेजेंट इंसुलिन है, उनको जनरेशन 1 बेसल इंसुलिन से। सर्वप्रथम कंपेयर करते हैं ग्लार्जिन 100, जो पुरानी इंसुलिन जो हम लोग पिछले 15 वर्षों से यूज करते हुए आ रहे हैं, उसको ग्लार्जिन 300 से, जो कंपेरेटिवली अभी न्यूअर इंसुलिन है। तो देखिए इंसुलिन है ग्लूकोज लेवल कम करेगी। दोनों इंसुलिन जब हमने 1 ईयर की स्टडी में देखा गया, दोनों इफेक्टिव थी। HbA1c कम किया, फास्टिंग और पोस्ट प्रांडियल वैल्यूज में इक्विवेलेंट इनके प्रभाव रहे, लेकिन फर्क कहाँ रहा? बेटर HbA1c रिडक्शन जो मिनिमल था, लेकिन एट द कॉस्ट ऑफ लोअर हाइपोग्लाइसीमिया। ग्लार्जिन 300 के साथ हाइपोग्लाइसीमिया की संभावना कम रही, वेट गेन भी कम हुआ। तो इस प्रकार से बेसल 2 जो सेकेंड जनरेशन बेसल इंसुलिन थी ग्लार्जिन 300, वो ग्लार्जिन 100 से कंपैरेटिवली बेहतर पाई गई। जब इनके हाइपोग्लाइसेमिक पोटेंसीज को और डिटेल में डिस्कवर किया गया, स्टडी किया गया, एडिशन 1, 2, 3 और इन सब ट्रायल्स में एक सीरीज ऑफ ट्रायल्स हुए जनरेशन 1 और जनरेशन 2 को कंपेयर करने में, सब में देखा गया कि जनरेशन 2 जो ग्लार्जिन 300 इंसुलिन है, इट वाज फाउंड टू बी बेटर देन ग्लार्जिन 100 इन टर्म्स ऑफ थ्रू आउट 24 आवर हाइपोग्लाइसीमिया या नॉक्टर्नल हाइपोग्लाइसीमिया में। दोनों में ग्लार्जिन 300 वाज फाउंड टू बी बेटर देन ग्लार्जिन 100। आइए दूसरी बेसल इंसुलिन सेकंड जनरेशन की बात करते हैं, इंसुलिन डिग्लूडेक। जब इस इंसुलिन डिग्लूडेक को ग्लार्जिन 100 जनरेशन 1 से कंपेयर करके देखा गया, तो क्या देखा गया? ग्लाइसेमिक कंट्रोल लिटिल बिट बेटर है, फास्टिंग कंट्रोल इक्विवेलेंट है, लेकिन पोस्ट प्रांडियल में भी, बिकॉज इसका असर थोड़ा और प्रोलॉन्ग था, तो पोस्ट प्रांडियल कंट्रोल भी इससे और बेहतर मिला, और एट द कॉस्ट ऑफ नो एडिशनल वेट गेन। तो एक बेटर ग्लाइसेमिक कंट्रोल इंसुलिन डिग्लूडेक के साथ मिला, हाइपोग्लाइसीमिया के चांसेस कम रहे। तो ग्लाइसेमिक कंट्रोल बेटर, हाइपोग्लाइसीमिया लेसर, और क्या चाहिए? तो इस प्रकार से जो दोनों जनरेशन 2 इंसुलिन थी, वह हमको जनरेशन 1 इंसुलिन से बेहतर सिद्ध हुई। जब इनके हाइपोग्लाइसेमिक टेंडेंसीज को देखा गया, तो जहां ग्लार्जिन 300 थ्रू आउट 24 आवर भी इफेक्टिव थी, हाइपोग्लाइसीमिया कम था, नॉक्टर्नल में भी इफेक्टिव थी, हाइपोग्लाइसीमिया कम था। इंसुलिन डिग्लूडेक के साथ देखा गया कि नॉक्टर्नल हाइपोग्लाइसीमिया तो कम है, लेकिन 24 आवर हाइपोग्लाइसीमिया की टेंडेंसी इसमें कम नहीं देखी गई, शायद प्रोलॉन्ग ड्यूरेशन ऑफ एक्शन के कारण से जो डे टाइम हाइपोग्लाइसीमिया की प्रेवलेंस इसमें बनी रही। लेकिन ग्लाइसेमिक वेरिएबिलिटी डेफिनेटली जो इंसुलिन डिग्लूडेक की थी, वह फर्स्ट जनरेशन इंसुलिन के मुकाबले बेहतर रही। तो इस प्रकार से हम लोग क्या इस कंपैरिजन स्टडी से क्या सीख सकते हैं, क्या समझ सकते हैं कि जनरेशन 2 बेसल इंसुलिन जो कि 24 आवर्स से ज्यादा एक्ट करती रहती है, वो बेहतर स्टेबल सपोर्ट देती है, प्रोलॉन्ग एक्शन है उनका, जिसके कारण से ग्लाइसेमिक वेरिएबिलिटी कम होती है। और यदि किसी पेशेंट को अपने समय पे इंसुलिन ना ले पाए, 1-2 घंटे आगे पीछे हो जाए, तो जैसे ग्लार्जिन के साथ थोड़ा सा उसमें कंट्रोल डिस्टर्ब होने लग जाता है, यहाँ पे एक्शन इनका 24 आवर प्लस होने के कारण से डोजिंग प्रोफाइल भी थोड़ी फ्लेक्सिबल है कि 2-3-4 घंटे भी अगर आगे पीछे हुआ तो ग्लाइसेमिक कंट्रोल बिगड़ता नहीं है। वेट गेन और भी कम रहा, ग्लाइसेमिक कंट्रोल और इफेक्टिव और सस्टेन रहा जनरेशन 2 इंसुलिन के साथ में। टाइट्रेशन के दौरान हाइपोग्लाइसीमिया की पॉसिबिलिटी और कम रही, मेंटेनेंस के दौरान भी कम रही, और नॉक्टर्नल हाइपोग्लाइसीमिया विशेष रूप से ये न्यूअर जनरेशन 2 बेसल इंसुलिन के साथ जनरेशन 1 इंसुलिन के कंपैरिजन में कम पाया गया। तो ये एक बात तो सिद्ध होती है इन स्टडीज से कि जनरेशन 2 इंसुलिन यानी ग्लार्जिन 300 और इंसुलिन डिग्लूडेक, ये जनरेशन 1 जो डेटेमिर और ग्लार्जिन 100 से एक बेहतर मेडिसिन है, बेहतर इंसुलिन है। लेकिन शायद इससे अभी हमारा पर्पस सॉल्व नहीं होता। ग्लार्जिन 100 या जो जनरेशन 1 इंसुलिन है वो जनरेशन 2 से दोनों ऑल टुगेदर डिफरेंट एंटिटीज है। उसमें हमने जनरेशन 2 को बेहतर पाया, लेकिन जनरेशन 2 की दोनों इंसुलिन में कौन बेहतर है कौन कम बेहतर है, इसका प्रमाण कैसे मिले? तो इसके लिए इन दोनों को कंपैरेटिव स्टडी इनकी करनी होगी, बट दिस इज अ वेरी डिफिकल्ट टास्क because it is just like comparing two apples together, which means be actually not different at all. लेकिन करने की कोशिश की गई। आइए हम लोग देखते हैं कि क्या स्टडीज हैं जो इन दोनों को डायरेक्ट हेड टू हेड कंपैरिजन में देखने को मिला। ग्लार्जिन 300 एक पुरानी इंसुलिन की ही और कंसंट्रेटेड फॉर्म थी। तो जो कंसंट्रेटेड फॉर्म है सबक्यूटेनियस स्पेस में जाने के बाद स्लोअर रिलीज होगी, स्लोअर एब्जॉर्प्शन होगा, प्रोलॉन्ग्ड एब्जॉर्प्शन होगा, इससे फार्माकोकाइनेटिक्स इसकी डिफरेंट हो जाती है। जबकि इंसुलिन डिग्लूडेक के साथ में सेम इंसुलिन को लॉन्ग चेन फैटी एसिड को लॉन्गर चेन फैटी एसिड के साथ और जिंक के साथ जब हमने कंबाइन किया तब इसका जो फार्माकोकाइनेटिक प्रोफाइल है वो और प्रोलॉन्ग हुआ।
सर आपके पास 3 मिनट शेष है।
ओके, तो जो ब्राइट स्टडी जो पहली स्टडी थी जिसमें इन दोनों को हेड टू हेड कंपेयर किया गया, ग्लार्जिन 300 को और इंसुलिन डिग्लूडेक को, उसमें क्या देखा कि दोनों इक्विवेलेंट हैं। HbA1c 1.6% तक कम होता है हमारे 6 मंथ्स में, लेकिन हाइपोग्लाइसीमिया के चांसेस वह टाइट्रेशन पीरियड जो इनिशियल टाइट्रेशन फेज था उसमें ग्लार्जिन 300 के साथ बेहतर है। तो ग्लार्जिन 300 वाज सुपीरियर इन ड्यूरिंग टाइट्रेशन पीरियड। ग्लाइसेमिक वेरिएबिलिटी भी ग्लार्जिन 300 के साथ कम रही इन कंपैरिजन टू इंसुलिन डिग्लूडेक। जो पीक इफेक्ट थे इंसुलिन के पीक लेवल्स थे वो डिग्लूडेक में ज्यादा थे, ग्लाइसेमिक वेरिएबिलिटी डिग्लूडेक में ज्यादा थी ग्लार्जिन 300 के कंपैरिजन में। जब इनका CGMS डाटा दोनों को कंपेयर किया गया तो देखा गया टाइम बिलो रेंज, मतलब चांसेस ऑफ हाइपोग्लाइसीमिया वाज मोर विद इंसुलिन डिग्लूडेक, स्पेशली मिडनाइट हाइपोग्लाइसीमिया। हाइपोएल्ब्यूमिनीमिया होने पे, क्योंकि लॉन्ग चेन फैटी एसिड ये एल्ब्यूमिन से अटैच होती है, तो अगर एल्ब्यूमिन लेवल कम है पेशेंट का तो हाइपोग्लाइसीमिया के कम चांसेस बढ़ जाते हैं, यह भी इनमें देखा गया। न केवल टाइप 2 डायबिटीज में बल्कि टाइप 1 डायबिटीज में भी देखा गया कि थ्रू आउट द डे तो दोनों इंसुलिन एक जैसी थी, लेकिन नाइट टाइम में ग्लार्जिन 300 वाज फाउंड टू बी बेटर ओवर इंसुलिन डिग्लूडेक।
सर प्लीज रैप अप।
श्योर, द लास्ट 3 स्लाइड्स ओनली। शायद ये जो प्रभाव थे ये कंसंट्रेटेड इंसुलिन होने के कारण से थे। तो इंसुलिन डिग्लूडेक की भी एक मोर कंसंट्रेटेड फॉर्म, इन प्लेस ऑफ इंसुलिन डिग्लूडेक 200 को कंपेयर किया गया 300 से, ग्लार्जिन 300 से, और यहाँ पे देखा गया इंसुलिन डिग्लूडेक जो कंसंट्रेटेड फॉर्म है इसके साथ हाइपोग्लाइसीमिया कम होते हैं। तो शायद हाइपोग्लाइसीमिया के पीछे जो कंसंट्रेटेड इंसुलिन है दीज कुड बी बेटर। इंसुलिन डिग्लूडेक की डोजेस के साथ एक एडिशनल एडवांटेज है कि यह कम डोज में ज्यादा एफिकेसी ऑफर करती है। तो इस प्रकार जो हम लोगों ने बेसल इंसुलिन जनरेशन 1 और जनरेशन 2 यह दोनों को कंपेयर करके ये जाना कि जनरेशन 2 इंसुलिन 1 से बेटर है। आउट ऑफ 2 जनरेशन 2 इंसुलिन ग्लार्जिन 300 से हाइपोग्लाइसीमिया की प्रोबेबिलिटी कम है, ग्लाइसेमिक वेरिएबिलिटी कम है। इंसुलिन डिग्लूडेक हमारी लोअर रेंज में ही ज्यादा काम कर जाती है, कंपैरेटिवली लोअर डोजेस में ये ज्यादा इफेक्टिव होती है। तो इस प्रकार से हम ये कह सकते हैं कि जनरेशन 2 इंसुलिन आर डेफिनेटली बेटर देन जनरेशन 1, एंड आउट ऑफ 2 इंसुलिन इन जनरेशन 2 both are relatively equivalent with little bit plus and minus with both of them. धन्यवाद।
धन्यवाद sir for this lucid presentation. एक question है. This is from Dr. Suhail Durrani. So the question is, so your comment on IDEG in CKD, especially with low albumin levels. We know IDEG attaches to albumin. Is there a risk of hypoglycemia in CKD stage 4 and 5 with this insulin?
बहुत अच्छा इन्होंने इसमें एक डीप इंसाइट के साथ ये क्वेश्चन पूछा. वास्तव में हाइपोएल्ब्यूमिनीमिया के साथ में ये स्टडी की गई कि जिनका एल्ब्यूमिन लेवल कम था उनमें हाइपोग्लाइसीमिया के चांसेस बढ़ जाते हैं. हाइपोएल्ब्यूमिनीमिया का कॉज मेल न्यूट्रिशन रिलेटेड था, लिवर डिसऑर्डर था, रीनल डिसऑर्डर था, यह उसमें स्पेसिफाई नहीं किया गया. अगर हम इस डाटा को एक्स्ट्रापोलेट करें तो शायद हम ये कह सकते हैं कि सीकेडी के पेशेंट्स में जिसमें हाइपोएल्ब्यूमिनिया की संभावना ज्यादा है, शायद इंसुलिन डिग्लूडेक, क्योंकि एल्ब्यूमिन ही कंबाइन करेगा लॉन्ग चेन फैटी एसिड से इंसुलिन डिग्लूडेक से. जब वो कंबाइन नहीं कर पाएगा तो ज्यादा इंसुलिन डिग्लूडेक हमारी फ्री और अवेलेबल रहेगी. हाइपोग्लाइसीमिक चांसेस शायद ऐसे केसेस में अधिक हो.
पंकज, बहुत बढ़िया, बहुत अच्छा लगा आपका ये हिंदी भाषा में सुनना. थैंक यू वेरी मच फॉर योर प्रेजेंस एंड योर एक्सेलेंट लेक्चर. थैंक यू पंकज.
धन्यवाद.
Thank you, sir. So moving on, dear colleagues and friends, we have Dr. Ms. Meenakshi Bajaj. The topic she'll be dealing with is micronutrient intake in India. What does the latest data say? So Meenakshi Bajaj is dietitian at Tamil Nadu Government Super Specialty Hospital, Chennai, and she is a member of Indian Dietetic Association. She has been the past president of Indian Dietetic Association. Over to you, ma'am.
A very good evening to one and all. At the outset, I'm truly grateful to Dr. Anup Mishra sir and his entire team for giving me the opportunity to be talking to you on this special topic. How much it interests every one of us is the macronutrient intake in India, the latest data. I'll be taking you in the next 10 minutes through the data which has been collected by the NNNB survey, which has been done throughout the country. That is in 16 states, 6 regions, that is the urban data, and through the 10 states in the rural regions it's the 10 states, 4 regions in the rural. So every time we drink or eat, you're either feeding a disease or fighting it. And as per IDF 2021 stats, we understand that diabetes hits the poorest, hardest. Over 4 in 5 with diabetes live in low and middle income countries. And with India, when we talk of whether the prevalence of diabetes or undiagnosed diabetes or pre-diabetes, we see the numbers are soaring and it's a matter of worry. Whenever we look at, diabetes or any metabolic disease, we understand both diet and diabetes go hand in hand. And how do we explain this in a very simple way? During the post-colonial independent India, did we see the prevalence of diabetes being very, very high? No, it was on the lower side. And today's date, it is much high. I think we have enough data to tell us that. And unfortunately, the reason being repeated invasion by the Arabs and the Mughals, followed by the British colonization, which in turn led to inadequate quantity of the, basic food which one would require during those days. And today, I think we are moving in the phase of refeeding syndrome, where there is exponential, access to food, whether it's the urban or the rural, though there is a percentage of population which is still undernourished. And, when we talk of India and diversity, all of us know that we are diverse when it comes to tradition, religion, practices, food, everything. But still there is unity in diversity. And I would say when it comes to diet, what is the unity in diversity? Unfortunately here, the unity in diversity is the carbohydrate consumption, which is the main component, which was based, this data has been obtained from a systemic review, which showed that in India, 41 different dietary patterns have carbohydrate as the main component. I think this August audience is aware of the Starch study, which very clearly tells us that the imbalance in the food, especially in the carbohydrate consumption, whether it's the quality and the quantity. And the Starch study very clearly tells us, which was published in 2014, that 66.8% of the total energy, when it came to the non-diabetic participants, was so high in the total energy intake coming from carbohydrate. Where do we stand today? Now, if you look at this data, it very, very clearly tells us that whether it's the urban or the rural India, it's the eastern part of the country. You look at the urban population, in the eastern part of the country, 81% is carb consumption. followed by west and south of India, which is about 77% coming from carbs, and central India is 13%. Now, looking at the rural part of the country also, you look at a similar sort of a picture. It's 86% in eastern, south is 83%, west is 81%, and 77% central India. Whatever said and done, we are much higher than the 2014, which was 66.8%. Now, coming up to deep diving into the calorie, carbohydrate, fat, protein, we understand though there's a very marginal difference in the rural and urban India in terms of calories, but look at the carbohydrate intake. It's much high in the rural India when compared to the urban India. But still, all of us are aware that the prevalence of diabetes is much lower in rural India than urban India, though the carbohydrate consumption is high. Probably I could just point a few pointers on the reason behind it. Obviously, we are aware that millets play a major role when it comes to the rural part of India, but portion control is equally important and physical activity. But second important thing which we tend to miss out or understand is the resistant starch. When it comes to the pulses or the legumes or the bananas, that is the green bananas, or coming to the rice which has been cooked and cooled and then consumed, all these are forms of resistant starch. And when we talk of in the southern part of India, we talk of the term called palayadu, which means rice has been cooked, cooled, kept overnight, and then consumed the next day, wherein the resistant starch is as high as 2.5%. It's also interesting to note that the green gram dal, which is consumed often, as well as the junka and the amti, which is consumed in Maharashtra, the chole, which is consumed in the northern parts of the country, are all sources of resistant starch. So I think this small pointer will help us understand that why is there some relationship with the prevalence of diabetes and resistant starch. Not only that, if you look at the fat consumption, total fat consumption is much lower in rural India when compared to urban India, and the total protein is much higher in the rural India when compared to urban. Especially the protein which comes in rural India is mainly from the pulses, nuts, oil seeds, where once again we talk of the presence of healthy fat and the presence of resistant starch, soluble fiber, and some amount of insoluble fiber. And also it's interesting to note that the protein consumption is more from plant protein, the reason being cost is an important factor. And you deep dive down and see into this table, which gives us some little information that the carb intake is as high as 295 grams in the rural India. I'm talking of the mean macronutrient intake. And when it comes to the urban India, it's about 212 grams. Whereas the My Plate of the National Institute of Nutrition very clearly tells us that we require not more than 282 grams if one is consuming 2000 calories. And the protein consumption is to be as high as 60 grams. And the fat consumption is to be as high as 56 grams. This will give us the totality of the 2000 calories which one consumes. Now, when we're talking of totality of consumption of these various food ingredients, we understand with this table that the cereals, the millets, the pulses, the legumes, as well as also, apart from the plant-based proteins, also the meat, poultry, fish, and seafoods is consumed on a higher basis in the rural portion when compared to the urban India. And when it comes to the urban part of India, we understand that vegetables, roots, fruits, fats and oils, nuts, and as well as the miscellaneous is consumed on the higher side. But it's interesting to note that the most of the fruit and the vegetable which is consumed is the potato and the bananas, which all of us are aware that the potatoes and bananas are high in index and high in glycemic load, which in turn worsens insulin resistance and obesity. On the other hand, if you're going to choose the potatoes, today's date, potatoes are being consumed from I would call it as the king of the roots and tubers, wherein it has been consumed not only in the form of puri potatoes or in the form of, today's date in the form of a burger or a French fry. So all these are going to be not only going to give you high glycemic index, load, calories, trans fat and saturated fat alongside in the medium in which it is prepared. Cereal consumption of total energy intake in the rural is about 97.1%. Urban is 68.8%. It's way high. And when you look at the cereals here, the NIN very clearly tells us we need to go around about 45% of the total energy intake. And the milk consumption is high in the urban population. As I mentioned to you previously also, the vegetable consumption is high in the urban population. But to add on to it, we have the processed and the ultra-processed snacking pattern, which is as high as 10%. And unfortunately, even in the rural population, it is moving slowly and touching as high as 4%. I think that could, sort of relate to the abdominal obesity in the rural and the urban population. I think we are very, very, well aware that today's date, we talk more of, instead of the kavani rice and the basmati rice and the brown rice and the parboiled rice or the red rice, we are moving towards more of polished rice. Even when one talks of millets in the urban population, one is consuming more so only polished millets. And even the PDS is offering, at least in South India, it offers more of polished rice, and in the northern parts of the country, it's different cereals. So when it comes to fruit and vegetable consumption, we are aware that the total consumption is on the lower side. When it comes to the protein part of it, a similar pattern is observed both in the urban and the rural population. You will see that the central part of India is consuming more of plant protein, both urban and rural. And when it comes to animal protein, it has been consumed more in the southern part of the country, both in the urban and the rural part of India. Whereas one thing you need to understand here is, there is basically, we expect a protein intake of about 60 grams, but we are going a little low, both in the rural and in the urban population. When it comes to the visible and invisible fat, here we need to, have it in inverted commas. What I mean by saying visible fat, according to this NNMB survey, was oil and fat from the fried snacking, from meat and poultry. And when it came to the invisible fat, nuts, pulses, oilseeds, also cereals have very small quantity of invisible fat. When you look at the data, when it comes to the urban and the rural, you understand that the invisible part of the fat has been consumed more in the rural. Why not? Why is it consumed more in the rural? You will see that it is consumed more from nuts, pulses, and oilseeds, and not from the fried snacking. Yes, ma'am. Another 2 minutes and I'm through. And when it comes to the visible part, which is consumed more from milk, meat, poultry, and fat, it is more in the urban population. So this is where we are seeing that a lot of trans fat, saturated fat from processed and ultra processed snacking. And India, with the help of government of India, FFCCI has announced a trans fat free India by 2022 and globally by 2023. If you look at this data, my plate versus my present plate, we understand that the vegetables which are consumed in the urban area, only 17% of the urban area meet the recommended 400 grams, that is 75 grams coming from the fruit and 300 grams coming from vegetable. And in the rural population, only 8.8% meet this recommendation. Whereas when it comes to nuts and oil seeds, also a similar pattern is seen in the urban and the rural. Are we different in North India, Northeast, West, Central India? Yes, we are a little different. North India consumes a lot of fat intake. Northeast India, high in calories, high in carbohydrate, as well as the plant protein is also high consumption in Northeast India. Whereas East part of India consumes a lot of fruit and vegetable, and unfortunately, Calcutta consumes the least part of it. When it comes to Central and Western India, you see high protein intake in Central India, but still we are not touching the recommendation of 60 grams. Milk and milk products is highest in the Western India. As I mentioned to you previously, already the South India is consuming a lot of invisible fat and protein coming from the animal-based protein. So if you look at this is the last slide, which talks to you that in South India, the urban population, you find the prevalence being as high as 29%, and it is rice consuming and snack consuming. In Northern India, we have a lot of fat consumption, which is touching as high as 67 grams, whereas we require only 56 grams. Northeast urban is highest carbohydrate consumption as well as protein consumption, and they don't, rely too much on snacking pattern. In Central urban India, we see the prevalence being 18%, least in the lot, and they are more so wheat consuming pattern and no snacking at all. For that matter, if you look at the scientific report, it clearly tells us that high total carbohydrate is associated with metabolic syndrome. And the best method of, talking or tracking the metabolic diseases is by reducing the carbohydrate intake. But I would say we have this elegant study from Lancet, which tells us not to go below 50%. So no fat diets, but to go with a balanced diet and position lifestyle medicine in the promotion of overall health. So if you want to chisel your way back to good health, no fat free, no carb free, but go to balanced diet and you are what you eat. Thank you for your patient listening.
Thank you, ma'am. Thank you so much to be on time. There's one question I would want to ask. What is the single most important change in macronutrient, which you can say is present in the last 2 decades in India?
I would say I think from carbohydrate, we've again touched to carbohydrate only, and it's the type of carbohydrate along with the quantity of carbohydrate. So I think we are moving more in the consumption of the processed foods, are walking into our, daily diet pattern, and we are walking into more energy dense than nutrient dense.
Thank you. Meenakshi, that was wonderful presentation. What she did not write, being humble as she is, that all these data are going to be published in European Journal of Clinical Nutrition. She's worked very hard over it in the last 4 months. Well, Meenakshi, you can write below that Meenakshi et al. European Journal
Sir,
of
I
Clinical
owe
Nutrition.
it to you totally, sir. I'm grateful to you totally. The
Nice.
dream and the vision and the design of the study is purely yours.
Thank you so much for presenting those data here, which will be available to the world in shortly once it's published. So thank you, Meenakshi, once more. There is one more question, but I think that question about almonds and glycemic index of food, if almonds are taken before the meal, I think we should take with Dr. Seema tomorrow, because she has done a number of studies with almonds. So with that, we move on and we go on to the next lecture. I think that's a very, very important lecture here. Delivering this lecture on the Pheneron, the new drug for kidney disease, is Dr. Sanjeev Gulati. Dr. Gulati is one of the foremost nephrologists in India and very well known. He has done a number of research studies when he was in Sanjay Gandhi Institute, and his studies are still top-notch as far as metabolic syndrome is concerned, and he is the best person to speak on Pheneron in diabetic kidney disease, rationale and evidence. Sanjeev.
Thank you, sir, and good evening, everyone. At the onset, I'd like to thank Professor Anup Mishra as well as Team C-DOC for inviting me yet again to this symposium. This has emerged over the last few years as a one-stop place where you can update your knowledge about all kinds of metabolic syndromes and diabetic kidney disease. And I personally gained a lot being a part of the faculty and learning from others. So the topic that has been assigned to me is the Pheneron in diabetic kidney disease. And when I think of this molecule, I'm reminded of this quote from late President Kalam's book, Wings of Fire. The actual quote is by Alvin Toffler, and it says, "The illiterate of the future are not those who can't read or write, but those who cannot learn, unlearn, and relearn." And in that sense, this molecule is a sort of relearning strategy in the management of diabetic kidney disease, targeting an entirely new pathway, as I shall show you. Now, these are, we all know that diabetic kidney diseases emerged as the commonest cause of chronic kidney disease world over, including our country. Our studies from Sanjay Gandhi PGI in 1999 were among the first to document that diabetes, even in a developing country like India, was the commonest cause of stage 5 CKD. And this was subsequently validated by studies from Professor Mani's group, Apollo Chennai, as well as PGI Chandigarh and All India Institute of Medical Sciences. Now, this is what these are the current therapies we have for managing patients with chronic kidney disease and type 2 diabetic diseases. They primarily target the hemodynamic and the metabolic factors. So hemodynamic, we have done that for the last 2 decades with ACE inhibitors and ARBs, thiazide diuretics, meticulous blood pressure control. Over the last few years, SGLT2 inhibitors have been added to the therapeutic armamentarium here. As far as the metabolic control is concerned, again, we had a lot of oral anti-hyperglycemic agents, metformin, then came the GLP-1 receptor analogs, and again, over the last few years, SGLT2 inhibitors have been targeting this pathway. Now, the third pathway, namely the inflammation and fibrosis, this was the one where there were no existing treatments, primarily no therapeutic agents were available with us. And the mode of action of therapies is shown. So it is here now that if we have to slow down the progression, and if we have to, this is the additional pathway that we have to target. Now, this is the pathophysiology behind this. Now, the mineralocorticoid receptor overactivation contributes to the inflammation and fibrosis. And this is now heralded as a potential therapeutic target to slow CKD progression. We already talked about the hemodynamic and metabolic, and this is the inflammation and fibrosis pathway we are talking about. So kidney and heart disease are associated with mineralocorticoid receptor overactivation. This has been known for years together. This overactivation leads to increased gene expression of pro-inflammatory and pro-fibrotic pathways like transforming growth factor beta and a number of other cytokines. Now, these newer drugs, the mineralocorticoid receptor blockers, by blocking this mineralocorticoid receptor, reduce the gene expression of pro-inflammatory and pro-fibrotic pathways, which, as I told you, are largely unaddressed by the previous therapies, and they provide dual cardio as well as renal protection. So this is what the molecule we are talking about today evening. It's called Pheneron. It's a novel, non-steroidal, selective mineralocorticoid receptor antagonist. It blocks TMR activation and it inhibits inflammation and fibrosis. And this is a proposed mode of action. As I told you earlier on, this is the mineralocorticoid receptor. So it binds and it causes a conformational change that is different from the change with steroid hormones and steroidal MRAs like aldosterone and epinephrine, which have been available for the last couple of years. So it blocks the transcription of the pro-inflammatory, pro-fibrotic genes, which causes this anti-inflammatory and anti-fibrotic action is there. There is also a homeostatic action on the epithelial cell. And as you can see, there is reduced podocyte damage, reduced mesangial cell proliferation, reduced macrophage transition to the fibrotic cells, the fibroblasts, and there is also it protects the epithelium, and there is a downstream effect in reduced urine albumin creatinine ratio and normalized urine sodium concentration, which are the biomarkers for kidney disease that are very easy to manage. So this is how it is different from the previous two molecules that we have. This is spironolactone, which has been there for years together. It has got a high potency for MR activation is high, selectivity is low, CNS penetration is there. There are sexual side effects like gynecomastia. All of us have experienced that in our practice. And the tissue distribution, much more in the kidney than in the heart, about 6-fold greater in the kidney than in the heart. Then came Pheneron almost a decade back, which had moderate potency. Selectivity was again moderate, again less side effects like gynecomastia than aldosterone, but not absent altogether. And again, much more effect on the kidney than on the heart. This again translates more into the hyperkalemic side effect, which we are all worried about, when we are managing CKD patients. And finally, we move on to the pharmacology of Pheneron. So look at this, it's much bulkier, and not only that, it is non-steroidal, so which has advantages as far as the tolerance is concerned, as far as the compliance is concerned, side effects is concerned, very high potency and very high selectivity. Again, there is no CNS penetration, there is no signal in phase 2 clinical studies. Hyperkalemia is there, but not as bad as with the previous ones. The reason being that there is a balanced tissue distribution, almost 1:1 in the kidney as well as the heart. So now we move on to the two trials that are available in literature. The only trials till date, we have the Fidelio Dkd as well as the Fiero Dkd trials, which were investigating the effects of Pheneron on reducing the renal as well as the cardiovascular morbidity and mortality in patients with CKD and type 2 diabetes. So there was, these are the two trials. In the Fidelio Dkd, about 5,734 patients were looked at, whereas the Fiero Dkd looked at about 7,400 patients. The clinical efficacy endpoint was a composite endpoint, renal endpoint, which is time to onset of kidney failure or decrease of eGFR of more than 40% or renal death. Again, the key secondary endpoints were the same as in the Fiero Dkd. This is the composite endpoint in the Fiero Dkd, which is time to cardiovascular death or non-cardiovascular events. And essentially, there was a run-in period, there was a screening period. There were two arms in the therapeutic group, 10 mg in the patients who had GFR between 25 to 60. Those who had more than 60 were given 20 milligrams of Pheneron, and there was a placebo arm in both these studies. Now, the Pheneron phase 3 program included patients with CKD and type 2 diabetes across the spectrum of CKD severity. So this is the different stages of CKD, stage 1 to stage 5. This is the different severities of microalbuminuria. So as you can see, the Fiero Dkd included patients in which was relatively more severe, whereas the Fiero Dkd included patients who were had slightly moderate, the earlier stages of CKD, but together they covered almost the entire spectrum of stage 1 to stage 3 CKD. Now let's look at these trials individually. We'll first look at the Fiero Dkd. So the key inclusion criteria were, now this is, what is interesting is this is on a background maximum tolerated dose of ACE or ARBs, which is the current standard of care. So these drugs were given in addition to that, and it would be unethical to deny these patients the advantage of these drugs. This study included patients who were more than 18 years with CKD and type 2 diabetes, pre-treatment with optimized therapy, including an ACE or ARBs, with the maximum tolerated dose for more than 4 weeks. Serum potassium, at least at inclusion baseline, should have been less than -4.8, and diabetic retinopathy for patients with type A2 albuminuria. Patients were excluded if they had non-diabetic kidney disease, if they had HFrEF with N/HA class 2 to 4, HbA1c is more than 12%, or uncontrolled arterial hypertension. So these are the stage, as you can see, stage 2, 3, A2 to A3 were included. These are the stages of CKD.
So 3 minutes to go.
Okay, this was, as I said, it was a randomized, double-blind, event-driven, placebo-controlled phase 3 trial, and the median follow-up was 2.6 years. At baseline, these patients had advanced CKD, adherence to treatment was high, cumulative treatment duration and number of permanent was similar. The primary outcome, on top of maximum tolerated RAS therapy, Pheneron significantly reduced the primary kidney outcome by 18%. So this is a hazard ratio of 0.82 as compared to the placebo arm, which was kidney failure, more than 40% decline in eGFR or renal death. And there was also, on top of maximum tolerated RAS therapy, it significantly reduced the risk of key secondary outcome, which is time to cardiovascular death, non-fatal MI or non-fatal stroke or heart failure by 14% hazard ratio, and this was significant. Now, the investigated reported hyperkalemia was increased, but the clinical impact was minimal. As you can see, very minimal hospitalization, certainly no deaths and no discontinuations. Again, highlighting this. Now, moving on to the Fiero Dkd, we already, so this is the second phase 3 trial. Fiero, the hypothesis was that Pheneron reduces cardiovascular mortality and morbidity and expands the evidence base to cover a broader range of CKD in type 2 diabetic patients. 7,437 patients. These were the cardiac and primary cardiovascular outcome. These were the renal outcomes I alluded to earlier. And median follow-up of 3.4 years. Baseline eGFR was 68 mils per minute, mean UACR of 308. Again, adherence was again high. No numbers of permanent discontinuation was similar between Pheneron as well as placebo. 99% were treated with the maximum tolerated of ACE or ARBs. This is the distribution of the different eGFRs in the study population. But these are the results. So primary composite outcome, time to cardiovascular death, non-fatal MI, non-fatal stroke, or hypertensive heart failure was reduced by the 13%. This is p-value was significant. This is the 12.4% in the Pheneron arm, 14.2% in the placebo arm. So this is the summary of the two trials. Fiero Dkd looked at stage 3, stage 4. Fiero Dkd looked at stage 1, stage 2. CKD progression was reduced by 18% in the Fidelio DKD arm, by 13% in the Fiero Dkd arm. Cardiovascular protection was there 14% in the Fidelio DKD arm, by 13% reduced CKD progression in the Fiero Dkd arm. And both trials showed that Pheneron was generally well tolerated, and the increased incidence of hyperkalemia had a minimal clinical impact. So adding to the evidence that from the Fidelio DKD trial, the Fiero Dkd results indicate that Pheneron indeed is an effective investigational treatment option for cardiovascular and kidney protection in patients with CKD across the entire spectrum, stage 1 to stage 4 and type 2 diabetes. Thank you for your attention.
Great lecture. Sanjeev, I have only one question for you. If you can unshare your slide, please.
Just, where is that? Stop share. Okay.
Yeah, okay. So one question, do you think this is a path-breaking event as far as nephrology is concerned, that Pheneron, a new drug, is showing so much of benefit as far as kidney endpoints are concerned, as well as the cardiovascular endpoint?
I think there's very little doubt. So as I showed you that we had, we had 3 pathways. And all along, CKD is inherently a progressive kidney disease. So limitation so far was over the past 3 decades, we have been able to target only 2 of these 3 pathways. And now at last, we have an additional agent where we are able to target the 3rd pathway. So I'm sure that with this drug being available now, we can add years to life and life to years of these patients who have got chronic kidney disease or secondary to type 2 diabetes, and which is a very difficult disease, which is inherently progressive. So definitely it's going to slow down. And the commonest cause of mortality in our patients too is the cardiovascular mortality. So here too, I think Pheneron is going to be a path-breaking therapy, adding on to the additional agents. A very exciting molecule, sir.
So, Sanjeev, as Rajiv Agrawal, who did these 2 studies, said in one of the lectures that the nephrologists were beggars as far as drugs are concerned, and now they are suddenly become richer. Cardiologists, Dr. Tapan is listening, were always rich, and they are becoming also richer and richer. So any drug which is acting on kidneys is actually acting on heart also. So thank you, Sanjeev, for once again for that wonderful lecture and giving us that new information about Pheneron. Thank you so much.
Thank you, sir. It's always been a pleasure to be part of the symposium, and I look forward to further learning during the course of the symposium.
Thank you. Thank you. Dr. Wagnu, are you there, sir?
I'm here only.
Oh,
I'm here only.
Sir, are you ready for your lecture?
Just can you give me 1 second only?
Sure.
Yes.
Let me. Yeah.
Yes,
okay.
yes.
Great. So let me introduce Dr. Wagnu. Dr. Wagnu is one of the legends as far as endocrinology in India is concerned. And he is not only an excellent researcher, but excellent clinician, and more importantly, a wonderful human being, my very close friend. And he speaks so well. So it's a pleasure to listen to him in any conference. And he'll be speaking about a very old drug, but a wonderful drug called gliclazide. So, Dr. Wagnu, you can start your lecture.
Thank you, Anup. Are my slides visible, Anup? Hello?
No, sir, it's not visible now.
Not yet? Just
Not
hold on.
Not visible as yet, sir.
Okay.
Share slide at the bottom.
Yeah.
Now it's coming, but yeah.
Now it is.
If you can,
What has up?
you can, make it smaller, a little smaller, because it's going out of the screen.
Okay. Just hold on. I don't know. Just it will go away. I don't know.
If you can go to the next slide, I'll tell you whether it is fitting or not.
No, something is coming here, Anup. Anyway, no problem. Yeah.
Okay.
Anup, thanks for your kind words. And today I'm going to talk in another 15 minutes about the navigating safety toward the euglycemia with the glycoside. It's not a new molecule, everybody knows about it. And if you see, Sanjay Kalra basically had published a consensus recommendations on SU and the SU combination, the management type 2 diabetes, the international task force, which was published way back in 2018. So the gist of the recommendation was that the oral anti-diabetic drugs still dominate the prescribing pattern for management of type 2 diabetes. And for decades, sulfonylurea have been important drugs in the anti-diabetic therapeutic armamentarium. And SU alone or in combination with the metformin have been the most commonly prescribed OADs. And unlike conventional SUs, the modern SUs such as glycoside MR and the glimepiride are associated with better safety profile. Individualization of the treatment using SU in combination with the other drugs, backed with the careful monitoring and patient education, ensures maximum benefits with the minimal side effects. You know, we published again an expert opinion from India in 2021 in the Endocrine and Metabolic Science. And what we said, the glycemic control is a very delicate balancing act. HbA1c or less than 7% is an effective and safe target for the euglycemia in non-pregnant adults. And glycemic targets should be individualized in special patient population. And the SU can be effectively and safely used for navigating type 2 diabetes patient towards euglycemia. And among all the SUs, glycoside is effective, safe in navigating type 2 diabetes towards euglycemia. Everybody knows about the conventional and the modern sulfonylurea. The glycoside and the glimepiride comes in the modern. And based on the mechanism of action, these are the glibenclamide, glipizide, and glycoside are the long-acting SUs. Now, glycoside is sulfonylurea with a difference. Unique mode of action is a pancreatic beta cell SUR1 specific, has a controlled and pulsatile insulin secretion. Efficacy is at par with the other sulfonylurea, and durability as per the advanced trial was very good up to 5 years. A low risk of hypoglycemia, a demonstrated CV safety and the renal safety and the weight neutrality. Now coming to the glycoside effectiveness, this was the basically a EMR based real world evidence from the UK, from the Kunti's group, which was basically published in 2020. What they did the comparative effectiveness of the glycoside modified release versus sitagliptin as a second line treatment after metformin monotherapy in patients with uncontrolled type 2 diabetes. And what they show that patients on glycoside modified release MR, 35% were more likely to achieve target A1C of less than 7% as compared to the sitagliptin, and 51% were more likely to achieve a target A1C of less than 6.5%. Again, a big percentage. And also, between the initial HbA1c and the final A1C achieved, patients on the glycoside MR were 11% more likely to achieve A1C reduction of more than 1%. Then came the Indian data, the Indian real world evidence by our own colleagues, Bipin Sethi, Sahai. And again, their data was based on the EMR, electronic medical record based, most of them are using the health pricks, effect of glycoside or glycoside plus metformin combo on glycemic control in patients with type 2 diabetes in India. It was a retrospective longitudinal observational study from the electronic medical record. And if you see that the beauty of this particular real world data was that across all the baseline, HbA1c baseline in all the study arm, whether the patient wanted glucoside add-on, combo with the combo add-on, there was a reduction across all the arms in this particular real-world evidence. Then came a model-based meta-analysis of 2029 studies from the Maloney et al. In 2019. This model-based network meta-analysis to compare the glycemic control, the weight change, the hypoglycemic risks across 24 anti-hyperglycemic drugs used to treat type 2 diabetes, mono, combo. And can you imagine the glucoside effectively reduces A1C by 1.04% compared to other oral drugs. Then again, a data to see the up titration, whether the up titration further improves the HbA1c or not. And they had this study Ezedia, where the glucoside was released in these graded doses of 30, 60, 90, and 120 milligram. And between all the quartiles of the HbA1c, there was an 1.78% decrease in the mean HbA1c. And if we say from the 8 to 10, baseline 8 to 10, there was furthermore 2.3% reduction in the mean HbA1c. I think long time back, Dr. Moore published a paper in JAPI in 2015, where he took 679 patients, and what they showed that about 10 out of 10 patients were able to achieve glycemic control less than 7% with glucoside XR 60 milligram. And with a simple two-step titration to administer maximum recommended doses is effective in achieving short-term glycemic control with a low-frequency hypoglycemia. And their group showed a A1C reduction of 1.4%. The GUIDE study, again, a very old data from the European Journal of Clinical Investigation, where they compared with another sulfonylurea had to with the glimepiride. And they could show the glucoside was at least as effective as the glimepiride. You know, glimepiride was always dubbed as having the maximum lowering HbA1c effect. Now, coming to the durability, after the effectiveness, we come the durability. And the ADVANCE was the major trial to show that the durability of maintaining the HbA1c lasted up to the 5 years, more than 5 years. And in the three categories, A1c less than 6 and less than 7, you can see the percentage of the durability in the intensive arm over the 5 years. So in short, if you see the glucoside, the sulfonylurea is with the difference, with the unique mode of action, with the pancreatic beta cell SGR1 specific, controlled and pulsatile insulin secretion, and efficacy we are already discussed, durability we have already discussed, and we have already showed the less degree of hypoglycemia. And number two, with the recent Pheneron trial about his cardiovascular safety, though it was with the glimepiride, not with the glucoside modified release, though we can have a sort of a comparative having the class effect of the sulfonylurea, though the slight different of mechanism of action, because the glucoside causes less hypoglycemia as compared to the glimepiride because it escaped the EPAC pathway. And so there is no persistent and constant hyperinsulinemia, which might be one of the cause of the low blood sugar. So Carolina was only difference between the linagliptin was the more incidence of the hypoglycemia, but with the glucoside, if you see, because of a unique mode of action, escaping the EPAC pathway, we expect a low incidence of hypoglycemia in our patient. So thank you, because it was a very short lecture, 15-minute lecture, and I'm afraid with Dr. Anup Mishra because he will see. You have to please do the, what you call the in crisp and short way within 10 minutes. I'm here with you, sir.
Thank you, Dr. Wagdu. That's a wonderful, that's what we wanted, a very crisp, very, very clear lecture, as always, as always. Now, Dr. Wagdu, there is one question from somebody has asked here. Now, in a patient who has established cardiovascular disease, which one will you choose, gliclazide or glimepiride?
I think very good questions. The established cardiovascular disease, And if you see the data is with the glimepiride, the recent data, the Carolina, where they have shown the non-inferiority trial in patients with CV complications. But I think the advanced trial did also show about its impact. And what I see, the glycoside modifier is because of its less impact on the hypoglycemia. And we know hypoglycemia is a major deterrent factor for the cardiovascular complication. I'll be very happy and safe to use glycoside modifier.
Great. Thank you. One more question here, Dr. Magnu. Many of us or many people use twice daily glycoside, while it is usually said that you should use it once because it has a 24-hour action. What is your practice, sir?
Yes, I always use a single dose, but in some preparation, which is the combo preparation along with the metformin, where I have to use the drug twice daily, because in that case, the metformin is not an extended release, it's the immediate release formulation. In those cases, I use, otherwise, if I'm using as a monotherapy, I use as a single dose. You're right.
Great. Thank you. Thank you, Dr. Magnu, for joining us. And it's always an enriching experience when you are speaking. Thank you once again.
I finished in 10 minutes or not?
Sorry?
I finished in 10 minutes or not?
Oh, you finished probably in 9 minutes, 50 seconds or something.
Excellent.
Thank you so much. Thank you so much.
Okay, bye-bye.
Bye. We move on to the next lecture, which is very, very important lecture. Dr. Caballero, you can open your video. Yeah, thank you so much, Dr. Caballero, for joining us. It's my great pleasure to introduce you, Professor Caballero. Just let me put the slide, just 1 minute. Yeah, that's good. So Professor Caballero is endocrinologist, clinical investigator, faculty director, International Innovation Programs, faculty director in Diabetes Education, Office of External Education, Postgraduate Medical Education, Associate Professor of Medicine, Harvard Medical School, and Director of Latino Diabetes Health, Boston, famous hospital, and chair in the Healthcare Disparities Committee, American Diabetic Association. So in short, he's a great educator. And sometime back, almost 1 year back, he invited me and 5 other people from all over the world to speak on diabetes and COVID-19. And I'm still thankful to him for that. And then that was a wonderful, the organization and wonderful conference. But also, following that, we published a paper, and that has been cited multiple times. So, thank you, Dr. Caballero, for taking out time to be with us, and thank you for agreeing for everything. So, please start your lecture.
Thank you so much, Professor Misra. It's really a pleasure and an honor to be here in this meeting with all of you. I really appreciate the invitation by Dr. Misra and the organizers, Dr. Ghosh and Dr. Gupta. I have been very fortunate to be in India in the past many times before. I am very familiar, I would say, with many of your wonderful cities and places and culture. I'm originally from Mexico, and I would say that I have always sort of embraced the similarity in cultures and our family orientation, our traditions, our family orientation, and obviously a lot of the culture in general. So it's really a pleasure to participate in this meeting. And as Professor Misra said, I was very fortunate to work with him last year. And I'll show you actually some of the thoughts around that towards the end. Let me just share briefly here. And I know that is a relatively short time, so I want to be sure that I accomplish the goals set during this time. And when I was talking to Professor Misra, I suggested this topic. And the reason is that there's obviously a lot of information in the field of diabetes, the scientific information in terms of what we can do with our patients. But I think in general, we're falling short in helping most individuals with diabetes, and that requires the art component. And I will tell you what I mean by that. Let me start by saying that this is definitely the best time in history in diabetes care. And during this Congress, during this meeting, you're listening, you're hearing a lot of the advances and some of the most recent guidelines and suggestions on how to treat our patients. And I think that's really fascinating. We have better understanding of the disease and its complications for sure. Science has really guided us in this journey about better understanding diabetes, both type 1 and type 2. We have better ways to make the diagnosis, different tests, but obviously I think the timing has become very important in identifying patients with diabetes. I think that there are not a lot of diseases that can be delayed or prevented. Certainly in type 1 diabetes, that's unfortunately not a reality yet, but it is for type 2 diabetes. And I think it is important to also acknowledge that we can delay the development of diabetes type 2, which is of course the most common type, through lifestyle modification, sometimes pharmacological interventions. And I think that's important to consider as well. Obviously, we have better ways to manage our patients in terms of the combination of lifestyle issues, pharmacological interventions, glucose monitoring, education. A lot of the things that we've done for years can certainly help a lot of other people as well. I think that in terms of the nutrition, physical activity, it's an old concept, but continues to be very relevant, the cornerstone for the management of diabetes still. So that's very important to remember as some of the key advances. And I think that there's no question that we have more medications than ever before for our patients with diabetes. There are here in the United States, where I practice, 12 different classes of medications for type 2 diabetes. And I think this is great. We have a lot more choices, better options perhaps, but there's also confusion about what to do with our patients. And I think it is important to be familiar. And I think that's the beauty of these Congress and many others that try to highlight the most recent information for everyone. Now, clearly, the other factor that I think is very relevant is technology. And I know there's going to be another lecture later on insulin pumps and other technologies. And I think this is fascinating. This is a great advancement in diabetes care. Both patients with type 1 and patients with type 2 diabetes have seen many of these benefits, not to mention continuous glucose monitoring that, of course, is not available to everyone, but it's a great advancement in how to monitor blood sugars almost every minute or a few minutes in our body. And then that with the insulin pumps, et cetera, it's been fantastic. Now, obviously, in patients with type 2 diabetes, this is not obviously generalized, but there are possibilities to do that in some cases. Of course, the challenge is cost, availability, affordability that continues to be a major problem for many of our patients around the world. But there's no question that we are enjoying many of these benefits at the present time. But what is the problem? That despite all these benefits, all these advances, patients with diabetes are not doing well. Here in the United States, where you may actually think that because of our economy and healthcare system, people are doing great, well, that's not exactly the case. There are, of course, a lot of people that are achieving targets, but many who are not. So let me show you this data here from the National Health and Nutrition Examination Survey. And you can see 3 different periods of time, 2005 to 2008, 2009 to 2012, in 2013 to 2016, represented by the different colors that you see here. And you see here whether people have achieved some of the classical targets. For example, here to the right, you see blood pressure and cholesterol control. A, which is A1C, blood pressure and cholesterol control, and then the 3 former plus non-smoking, which is of course another important target. Now, what you can see is obviously that the proportion of people that have achieved these targets is relatively small. We would like to see everybody achieving targets. That's not happening. The second thing that you're seeing is that the proportion has not changed over time. So despite many of these advances, and of course, the most recent information is not included here because this is all the way until 2016, but the reality is that we're not having the impact that we think that we should based on all these advances. So too many people not achieving targets and not changing much over time. Now, when we get into another area that I have particularly been very interested in, which is about what happens with underserved communities, with racial, ethnic minorities in the country and around the world, then the situation is even worse. Here you see the data in the wide population, which is, of course, the reference point here in the United States. And then you see that the possibility of achieving targets is much lower in the Black community and also in the Hispanic, the Latino community that I've been working with for many years. And these are mostly people that come from Latin America throughout the whole continent to live in the United States. And there are inequalities, there are differences, disparities in achieving many of these targets in many things. Now, why is that? I think that that brings a lot of the other elements that I will talk about in a few minutes, which is really all the social determinants of health that we need to consider as we implement treatment strategies for our patients. Now, the other big problem that we have is that we are spending too much money in diabetes care. I do not know the data in India and other countries in your region, but I am sure that you are spending a huge amount of money in diabetes care. And most of that money, I am sure, is not in treating the disease, but in treating the complications of the disease. Chronic kidney disease, dialysis, cardiovascular disease, amputations, blindness, strokes, etc. Here in the United States is not the exception. We did an analysis a few years ago, and you see the main points here in this slide. And it's really striking to see that 70% of all the money available in the Medicare system, which is a federally funded system to provide care to people above the age of 65 in the country, and we're talking about millions of individuals, 70% of the money is spent and only 10% of patients with diabetes. Now, who are these patients? Those, of course, with all the complications that I mentioned. So there are people who are extremely expensive for the healthcare system. And the reason is that we wait too long to intervene. We don't intervene on time. We don't treat diabetes. We wait until the complications are there. And of course, it's important to help those individuals, but that's not going to help any healthcare system. There's no healthcare system in the world that will be able to survive if we continue to do the same thing. We need to act earlier. We need to act sooner, and we need to do it in a smarter way, utilizing all that we have in our armamentarium to help our patients with diabetes. And the complexity of diabetes is enormous. Obviously, type 1 diabetes is a different story. And you know very well that that requires insulin treatment from the very beginning. Type 2 diabetes is quite complex, and it's great, as I said, that we have now many different targets to manage type 2 diabetes, but continues to be a complicated disease. It's evolving. It gets inexorably worse over time. Beta cell dysfunction continues to decline. And now we know very well that there's many actors in this drama of type 2 diabetes, including the central nervous system controlling appetite and satiety, insulin resistance, both in skeletal muscle and in adipose tissue, as well as in the liver, beta and alpha cell dysfunction, incretin dysfunction, and more recently, the acknowledgement of renal glucose handling as part of the pathophysiology of diabetes. And in your region, we know very well, and I have learned that from all the trips in the past to India, that you do have, of course, a tremendous risk for type 2 diabetes based on many of these abnormalities, particularly abdominal obesity, intra-abdominal fat, insulin resistance, beta cell dysfunction that may happen in very early stages in life. And all that may be related to some genetic predisposition, but a lot of things have to do with lifestyle. And obviously, as I said earlier, social determinants of health, socioeconomic factors, cultural factors that lead to all this. This is what we've learned from science. We know very well what type 1, what type 2 diabetes is, but as I said before, we're not acting in the way that we should. So it's important to remember that there's this flow throughout the diabetes continuum that leads to many of these problems. So at the beginning, people may have a normal blood sugars, then they develop what we call pre-diabetes, like impaired fasting glucose and impaired glucose tolerance, and then hyperglycemia. And we talked about the pathophysiology and many of the factors, the metabolic syndrome that plays a role. Now we know, interestingly, that some of the complications, the typical microvascular complications, and that's why I move them a little bit to the left to overlap with pre-diabetes, because they may actually start in the pre-diabetes stage, not necessarily when people develop diabetes. That was sort of the old concept. And cardiovascular disease, of course, can happen at any point in time, both from atherosclerosis. And now we need to recognize congestive heart failure. And I know that there are some lectures here in this symposium about that. And this is important because it's part of what happens in individuals with diabetes. But as I said earlier, many of them are developing the long-term complications. And that's what is really bleeding our societies and our healthcare systems as well. Now, I won't go through this because you know that it's been obviously discussed many times in the past, but we do have now more therapeutic options for our patients with type 2 diabetes. This is the most recent from the American Diabetes Association and the European Association from the Study of Diabetes. And what we know now is that cardiovascular disease has come front and center, as well with chronic kidney disease, in being recognized in our patients to be able to implement therapies. So now we need to choose whether we want an SGLT2 inhibitor, a GLP-1 receptor agonist. Again, these are expensive medications that are not always available, but that's what science tells us, that this is what we could and should do if possible. But we continue to use metformin, obviously, as first-line therapy, and some of the sulfonylureas, TCDs, DPP-4 inhibitors, many of the other options. So I think it's important to recognize, what are we trying to achieve? What are the targets, and what specific individuals would benefit from all this? So this is complicated, but I think it's guiding us from the scientific evidence from clinical trials in how we should really approach the management of our patients with diabetes. But let me finish here with some other thoughts that I think are very important for all of us in diabetes care. And as I said, is that we are not interacting with our patients properly. And when I say that, it's not that we're not just communicating well. It is that the healthcare systems are structured in a way that do not allow us to interact properly with our patients to really help them. What do I mean by that? You and I work in a healthcare system. We are the healthcare providers. We talk to our patients and we motivate them to improve their self-care behaviors. And that's great and good for some patients, but not for everybody. The healthcare system does not allow it to interact with them for a long time. We only have a few minutes. How can we do something really good in just a few minutes? That is really very difficult. Not to mention that we are forgetting about the other factors: social, cultural, financial factors, psychological issues in our patients. That's not something that we're doing routinely. So we do need to think a little bit more outside the box. And this is the term cultural humility. What that means for us as healthcare providers is to really try to get closer to patients and understand their problems. It's not just what we learned in medicine and the biomedical part, but it's all the other elements of an individual. Again, it's easy to say that, difficult to implement in clinical practice. And a few years ago, I also published this paper, and I wanted to come up with something that was practical, and I call it the A to Z list for the management of diabetes, with this emphasis on looking at things outside the box. And I can guarantee that every single one of these factors that are arranged in alphabetical order, not in order of importance, are crucial for the management of patients with diabetes. There is science behind many of these elements that tell us that we need to consider them when we interact with our patients with diabetes. Depression, for example, is often missed in clinical practice. Obviously, health literacy, education, adherence to therapies, nutrition, exercise, how people perceive their body weight, religion, socioeconomic status, the use of technology, all these are very important. And then in the end, zip it, it's an expression that as well, you will know, says, don't talk too much. And I think that in clinical practice, we are the ones that talk the most, not our patients. And I think that we need to better listen to their concerns. And that's the art that I was trying to bring to this presentation about how to better connect with our patients. And I want to finish with this thought, and Professor Misra alluded to that, and I was very fortunate to lead this meeting that, as he well pointed out, ended up in a very nice publication, and you see the reference at the very end, in which we were discussing with this pandemic, what have we learned? What are we going with all this? And eventually the pandemic will be over. And our hope, collective hope, is that we don't go back to what we were doing before, based on what I just expressed. So here's our idea that, in the past, we were just waiting for patients to come to us. We would provide them with our recommendations, care, etc., and they would go home. And then they would come back, who knows, in 3 months, 6 months, whenever. That's not a good model, because we're not really knowing what's happening when they're not with us. Here, during the pandemic, we can't receive and wait for people to come. We have to try to be more creative, try to connect with them via phone or telemedicine or videos or in any possible way. And I have to say, we have to say, this is a great idea for the future. So hopefully, as we move forward, we don't just go back to what we were doing before, but learn from this experience, being in touch with patients when they're not in our clinics or hospital is what the chronic model of care requires for diabetes and other diseases. I think this is absolutely crucial and important to consider, as well as the assessment of social determinants of health, all the financial and social challenges that our populations have. And I think that India is a perfect example of how things can be done, because I know that there's many programs, many activities that are being implemented trying to address many of these things. So I think this is crucial, and hopefully this will help us be better prepared for future disasters, hopefully not soon, but this is something that we need to learn from. So I would just finish saying that it is great that we have all the science, we just need to put it into practice, but not to forget the art of medicine that will always, always require our presence and our help with our patients. I appreciate your attention, and I will turn it over to Professor Misra in case there's time for some questions. Thank you very much.
Professor Caballero, that's wonderful. That's what we forget often, that we have to communicate better with the patients. And who better than you to teach all of us and all your students at Harvard and all over the world that we have to give some more time to the patient. Now we have one question for you, sir. You have dedicated your life to minorities and Latino population. We have a lot of not exactly minority, but underprivileged populations, which are similar to, sir, your Latino population. And we have a lot of trouble in communicating with them regarding agreeing to continue with their drugs. Some concerns are financial, of course, but even financially, if they're okay and can buy drug, but they often go to some other practitioners which are quacks or something, and they come back to us with a very high sugar and complications. How do you tackle your Latino community regarding this issue? Are you facing similar issues?
We are facing. Now, I think that there is, unfortunately, low education, low health literacy in these populations. And I think that education is absolutely key. Now, how to do it and how to gain trust from these individuals, it's a challenge. But my experience is that when the healthcare team gets closer to that community, based on language, for example. And I know that in India, for example, that's a major issue because I don't remember how many languages you have, but there's like huge and there's different cultures, which is fascinating, but at the same time makes it challenging to really try to work with different populations. But when people are really connected with that community and trust is built, I think that's what needs to be done. I think that the problem is just to come to encounters and say, this is what you need to do and follow it, because we're not acknowledging people's challenges and their beliefs, health beliefs, what they have in their mind. So we need to learn about all these things and try to get closer and maybe dispel myths. For example, one thing that we do with our population is that from the beginning, when they join our program, we have a series of activities that dispel myths that they have in their mind from the cultural perspective. For example, that diabetes is, God's destiny and that there's really nothing to be done about it. And we say, no, of course, you can actually do something here about nutrition, about alternative medicine, about many other things that they do. So it's to guide them. But I think education is probably key in establishing that trust. That's what we're trying to do. And obviously it doesn't work all the time, but I think that's probably the best bet we have.
So thank you, Dr. Caballero. I am sure Latino community there is very fortunate to have you as a physician, as a communicator, as an educator. That's wonderful, the way you talk, the way you communicate. So thank you for joining us, and we'll have more opportunities in the future to collaborate with you, sir.
Absolutely. Thank you so much, Professor Misra and everyone, and my heart all the way from Boston to all of you. Thank you so much.
Thank you so much, sir. We move on to the next lecture, and that's on the very latest technology. And that's what the purpose of our conference is, to mix and match the new with some established facts and the latest in the research. So I have for this lecture my colleague Dr. Amrita Ghosh, who's handling insulin pump, type 1 diabetes, polycystic ovaries. So all these are something which has a lot of research which has come in. And so I would like Amrita to talk about recent concepts in technology, specifically focusing on advanced hybrid closed loop system.
Thank you, sir. So to begin with, good evening, everyone. And we all know that there are different types of insulin pumps which is available. And at this moment, we use maximum of the time, the pump which is used is the tethered pump. That means there's a pump and it is attached to the body with the help of tubing. This is available in India. The second kind of pump is a patch pump. That means there's an insulin like a box you can see here. It's attached as a patch, like a Band-Aid patch, and the control is done by remote. This is a very small pump. There's no tubing attached here, as you can see. The third kind is the implantable insulin pump. This is very interesting, and there are very few cases all over the world on this kind of pump. To be precise, only 400 patients are using this kind of pump. So this is a pump which is implanted inside the body, and the pump always remains inside the body, and this is attached to the hepatic artery. This is a very cumbersome process, so a lot of people are not using this pump. This is very rare. Let's move on to the next one, which is closed loop insulin pump, which is also called as artificial pancreas. So here you can see there are two ports here. These two ports are, one port is for insulin, the other port is for glucagon, and this is a bihormonal pump. This is attached to, it communicates through the pump by the uses of sensor, and with the help of CGM, it regulates. This pump is not available right now. This is under a lot of research is going on for this pump. In the last decade, you must all agree with me that we have seen a lot of evolution in the system of insulin delivery system, right from the continuous subcutaneous insulin infusion, the pump which gives only insulin. Now we have something called as partial artificial pancreas. The new generation insulin pump can be divided into two parts. The first one is the sensor augmented pump, in which there's a system here, as you can see. This is attached to the body and it communicates with the sensor here. And this sensor will ask the pump to suspend the delivery if there's a low glucose, which is sensed by the sensor. but there's no algorithm to deliver insulin. The latest addition is the hybrid closed loop system, where a system where the insulin pump delivers insulin based on the sensor glucose reading, and there's an algorithm for this. Let's focus on what all pumps are available in India right now. So these two are the only insulin delivery pump, cannot only just deliver insulin, nothing else. Then we had this sensor augmented pump, which gives you alarm, okay, this person is going into hypo, the person can act on it. Then comes the sensor augmented pump with low glucose suspend. That means the pump will automatically shuts off when the sensor will sense a low glucose. And then came the first generation of hybrid closed loop, which is also called a 670G. This pump is not available in India. But very soon, we are going to get the latest and the most advanced version of insulin pump. This is called as second generation advanced hybrid closed loop system. This is yet to be launched in India, but very soon, I think by the end of this month or early next month, this pump is going to be available in India. So here you can see the pump is attached, there's a sensor, there's an interface on the smartphone, and what does this pump do extra than the previous pump? This pump communicates with the sensor, and the sensor will sense the blood glucose and tell whether the sugars are going low, whether the blood sugars are going high, and then accordingly the pump will work, and it can give you auto correction, auto boluses. So let's take a closer look at it. So the advanced hybrid closed loop system has a manual mode, and this manual mode will have options like suspend before low, suspend on low, and resume the basal. I'll explain it in the next couple of slides. And then the system will have an auto mode. This auto mode will have auto basal, which is the pump will give a basal insulin every 5 minutes. At this moment, for all my patients on insulin pump, I'm the clinician, I adjust their basal for them. So this will not have that option. I do not have to do it. Only in the manual mode, I have to do it only for 48 hours. Then there's an auto correction bolus. So the closer look on the manual mode. Every patient will be started on the manual mode for at least 48 hours, because to get the insulin delivery data, this data is used by the Smart Guard feature. So basal rate must be programmed when the patient is in manual mode, which the clinician will do. Then when used with the continuous glucose monitor, the automated suspended features like suspend on low, suspend before low, and resume will be activated. Now moving on to the auto mode. The auto mode is also called as Smart Guard feature. This will regulate the basal insulin in response to the real-time sensor glucose value. And as you all know about the new concept of time in range, this is designed to maximize the time in range for the patient who is using it. So the pump will try to get the blood glucose at around 70 to 180. It will vary in these ranges. The goal will be to spend 80% of the time in the Smart Guard feature to achieve the maximum time in range goals. And it will use a programmed for insulin to carb ratio, and active insulin time will be used for the bolus deliveries. And the auto bolus is used to correct the hyperglycemia and keep the person within the targeted range. Moving on to the Smart Guard features, as this is very explainable, that suspend before low. So, okay, the pump will suspend, but how will it do it? Let me explain that to you. So insulin delivery will stop if the sensor glucose is at or within 70 milligram per deciliter of the preset low limit. And if the pump is predicting that the sensor glucose will be 20 mg per deciliter above the low limit or less within the 30 minutes. Do not get confused by this. This is very simple. Here you can see the low limit is set at 60 milligram per deciliter. The insulin suspend will happen when the sensor glucose reaches 130 only. 130 is somewhere around like minus 70, okay? And then this is predicted, and again it will suspend when it is predicted to reach at 80 within the 30 minutes. So the pump is too smart to do it for you. Suspend on low, this is very simple. When whatever the low limit is set, the pump will stop when it reaches the low limit at that time. Resume basal, the basal delivery will resume after a minimum of 30 minutes, or if the sensor glucose is greater than 20 milligram per deciliter above the preset load or predicted to be greater than 40. So if you take this example here, the low limit is set at 60 here, and the insulin here you can see it has not resumed for the period of 90 minutes because the sensor glucose was not sensing it. It was sensing around 60. So as soon as the insulin resumed with the 90 minutes, when the sensor glucose reached 80 and is predicted to reach 100 within 30 minutes, then only the sensor will resume here. So the smart guard features, as I told you, the selection between the default setting of 100 milligram per deciliter and 110 or 120. So this is the way you decide. If you want a tighter control for your patient, maybe you can keep this at a lower, at 100 or 110. But the company setting is for 120. Basal insulin adjusts every 5 minutes based on the sensor glucose value. Here you can see these are the basal readings where the pump was given basal on auto. And the auto correction target is set as 120. That means whenever the sensor glucose is more than 120, the sensor will give automatic boluses for bringing down the blood glucose to the range of 120. And the auto correction delivered every 5 minutes if maximum basal is reached and sensor glucose is above 120. That means the pump has reached its maximum limit for basal, but still the blood glucose is not coming under control. The sensor will sense it, and again the auto correction will keep on happening after every 5 minutes. So this is very wonderful feature. This is example for the patient profile with auto basal and auto correction. Here you can see the patient had 43 grams of carb. The patient had a bolus of 9.1. The sugars were around 81, which was going well. Here you can see the patient was going into hypo. There's a cutoff of the basal here. There's an auto cutoff. And then again, the patient took his lunch, and again, the bolus was given. Here you can see at around dinner time, the carb content was 50 grams, but there was no bolus given at that time. So the pump sensed that there was no bolus given by the patient himself, and the sugar went up to 245. After every 5 minutes, there was a auto bolus correction with a maximum basal which was given by the pump, and ultimately there is a downward trend. So moving on to the research study, this was a study done in New Zealand in about 59 patients who were not a naive patient with automated insulin delivery. The age group was 7 to 80. It was a randomized open label 2-sequence crossover study. This study particularly compared the AHCL to sensor augmented pump therapy with predictive low glucose management. And each study phase was for 4 weeks, which was preceded by 2 to 4 week run-in and separated by 2-week washout. So this study was published in Diabetes Care. Here you can see the result. This is the sensor augmented pump, and here the red one is the newly advanced hybrid closed loop. So the time in target, which was set around 70 to 180, was observed more in the hybrid closed loop, advanced hybrid closed loop, when compared with only sensor augmented pump. Here you can see 70% versus 57%. And the advanced group had greater improvement in the overnight targets, which is clearly seen here without doing any hypoglycemia. So AHCL with automated correction bolus demonstrated significant improvement in the glucose control compared with sensor augmented pump with low glucose suspension.
Amita, you have 2 minutes.
Another study which compared 670G and 780G, which is the two advanced pump. It was a multinational study funded by NIDDK, 113 individuals. These patients were either on insulin pump or multiple daily injection. It was a 12-week run-in, 12-week crossover study. Here you can see these patients, there's a significant difference between the two groups here. So for the patient who were on the advanced hybrid loop, so here you can see there was a plus 2.4 hour per day when these patients achieved the TIR. So hyperglycemia was reduced without increasing hypo in patients with type 1 diabetes using advanced hybrid group, and which was commercially available at that time. So moving on to the last slide here, who is your ideal candidate for this kind of hybrid closed loop system? A person who is comfortable wearing both the pump and the sensor, who can test their blood glucose 3 to 4 times a day for calibration, who is aware about giving meal boluses, willing to learn and understand the advanced hybrid closed loop system, and willing to trust the system and not fully get dependent on it. So in conclusion, we all know that the recent technology advances in integrated CSII and with CGM, where the insulin delivery can be automated by sensor glucose driven algorithms, are very important. And the closed loop systems are designed to maintain glucose levels at a predetermined targeted by the linking CGM. The Minimed 780G is the latest edition, and this is going to be available in India in just a couple of months. And the study shows that the AHCL improves the time in range with less hypoglycemia. This is what we want in our patients. And please always choose correct candidate for maximum outcome. Thank you for your patient hearing.
Thank you, Dr. Amrita. Can you unshare your slide, please? Yeah, thank you for that wonderful lecture. It almost seems like a robo, this pump, such advanced technology. But I'm used to still that multiple insulins and mix and match of insulin. What do you think? If I have a group of patients who are on multiple insulin doses and one on pump, will the life of a patient who's on pump be prolonged? Or the mortality benefit or cardiovascular benefit? What do you think about it?
So ultimately, we want a tighter blood glucose control for your patients for getting all those cardiovascular benefit, and be it multi injections or pump, both can give that benefit to our patients. There is no head-to-head comparison when we talk about that pump is better in that case, that it prolongs life or it prolongs the cardiovascular benefit for a patient. But definitely, I would say with my personal experience with patients for past these many years, that pump definitely has an increased quality of life to those patients, because many of my type 1 diabetes patients with type 1 diabetes, they are sometimes they're fed up by the multiple injections which they're taking, because that's a daily injections for them. So they are very happy to be on the insulin pump, sir.
Great. Thank you, Amrita, for that very nice lecture.
Thank you.
So we move on, and I have a great pleasure in announcing the first Ahuja Bajaj oration. Just Abhimanyu, if you can unshare a little bit, let me just
sorry.
Introduce you.
Okay.
If you can unshare a bit.
Let me see. Stop share.
Yeah, just 1 minute. Give me a minute on this.
Okay, good. Is that good?
Yeah, I think this. So, I'll take 2 minutes, and that's what I told Abhimanyu.
Sure.
I'll take because the association of Abhimanyu with me dates back from All India Institute of Medical Sciences, when he was my senior resident. And even at that time, I remember, Abhimanyu, that you published about Hodgkin's disease in a very good journal. I don't remember the name of the journal, very high impact journal, using Kaplan-Meier analysis at that time. And we were all, we looked forward to you as far as your clinical acumen and your research was concerned. And then in your batch, you were one of the brightest person. And that you have proved over the period of time. To the viewers, to the attendees who are close to 1,000 now, Abhimanyu has written multiple chapters in Harrison textbook of medicine, and also he's the top of the world as far as the lipodystrophy research is concerned. You can see his biodata. This speaks volumes about his effort and single-minded focus on the research. 169 original papers and 108 review articles. Don't think that these are in any journals which are of 1 or 2 impact factor. There are 8, 9, 10, New England Journal of Medicine, Journal of Clinical Endocrinology, Metabolism, that kind of articles. First report of statin therapy in dyslipidemia for type 2 diabetes. So you see the first, these are trendsetters. First report of high MUFA. In fact, Abhimanyu is the first one who started the making people believe that high MUFA diet is actually a good diet. And then subsequently, so many studies have come. And I remember Abhimanyu's paper, which had just 10 to 12 subjects, but a wonderful paper where high MUFA diet was, and the insulin doses were found to decrease in those with a high MUFA diet. And most importantly, the number of genes, the mutations that he has discovered, which have actually made us better understand the pathophysiology of lipodystrophies and progeroid syndrome, but also the meaning of this is that we understand more about obesity and metabolic diseases. Patent holder in metroleptin therapy for generalized lipodystrophies. Journal of Clinical Endocrinology Metabolism. He did great job for 5 years, and I was there when he was associate editor. I would work with him, and it was a great experience. Mentored 7 faculty. One of the faculty I was there, and 37 fellows and 9 medical students. A member of multiple societies, and of course, AIMS has recognized him time and again. Editor of book Dyslipidemia, Pathophysiology, and Management. So, Abhimanyu, we are so honored to have you with us this evening, and we are all looking forward to your lecture. Now you can share the slide and please start the lecture.
Thank you, and I thank the organizers of the Ahuja Bajaj Symposium for giving me this opportunity to present the first oration lecture. And certainly my special thanks to you for giving me this honor. As an internal medicine resident and registrar, I had the good fortune to learn pearls of wisdom from both Doctors Ahuja and Bajaj. Interestingly, I took an elective in Unit 1 Medicine under Professor Ahuja as an intern to learn endocrinology, and was also registrar in Unit 2 under Professor Guleria and Bajaj before I left to pursue endocrinology fellowship training in United States. As you can see, I'm going to talk about management of dyslipidemias in type 2 diabetes, role of nutrition and lipid lowering drugs. These are my disclosures. But before I start my scientific presentation, there are a lot of, I want to acknowledge the role my training at All India Institute of Medical Sciences played in shaping my career as a student, intern, resident, and also senior resident. Clearly, it laid the foundation early in my career. They gave us inspiration and motivation to learn, to read the literature, draw inferences, good inferences from literature. And clearly there was super training to become a physician because a lot of diagnostic modalities were not available at that time. So certainly I have too many people to thank. First, I would like to thank Drs. Guleria, Dr. Pandey, Dr. Gopinath, who were my MD thesis advisors, and also would like to thank Dr. Kochupillai, Dr. Malviya, and Dr. Vinod Kochupillai for giving me inspiration to learn different disciplines of medicines, not just endocrinology, rheumatology, as well as oncology. Today, however, I need to pay tribute to 2 giants in diabetes and endocrinology, Professor MMS Ahuja and Professor J.S. Bajaj. And I hope my oration pays homage to these departed souls. Before I begin the scientific presentation, I need to tell a few anecdotes of my interaction with them. So as an intern in Unit 1, I had taken an elective. I was working with a young lady suspected of having insulinoma. And Professor Ahuja instructed me to send not only her fasting sample for glucose and insulin, but also my sample as a control. So I came there in the morning without eating the breakfast and asked someone to draw my blood, and we sent both the blood samples. And this illustrates his scientific approach in those early days of radioimmunoassays in India. He wanted more and more from us in terms of working up of the patients always. As far as Dr. Bajaj is concerned, you all know that he was an avid reader and a lifelong learner. Interestingly, I met him twice in the libraries. the first time in the DGHS library, which was close to All India Institute of Medical Sciences. The library was closing. I was coming out and I saw Dr. Bajaj also coming out of the library, and he saw me and he said, "Where are you going?" I said, "I'm going to my hostel." He said, "Can I offer you a lift?" And I definitely accepted his offer. And he asked in his own peculiar tone, "Pray, what were you doing in the library?" And I told him, "Sir, आज सुबह जब आप राउंड ले रहे थे, आपने एक पॉलीमायोसाइटिस और डर्मेटोमायोसाइटिस का केस डिस्कस किया जिसके बारे में मुझे कुछ नहीं पता था. So I came to the library to learn more about it." And you can imagine that in the next 5 minutes, when he dropped me to the gents hostel, he had asked me everything about the literature that I had reviewed about dermatomyositis and polymyositis. The next time I saw him was at All India Institute of Medical Sciences library, actually in the same evening when I had finished my MD medicine exam, and I already knew that I had passed it. The result was not declared by then. Interestingly, Dr. Bajaj was the internal examiner. So he saw me at the library and he said, "Bhai, aap yahan pe kaise? हम तो सोच रहे थे आप तो सेलिब्रेट कर रहे होगे हॉस्टल में, कुछ पी रहे होगे, लोगों को पिला रहे होगे." And I replied, "Sir, अभी तो आपने रिस्पॉन्सिबिलिटी दी है, कलम में और ताकत दे दी है." So I told him, "I hope I'm making sure that I can fulfill your expectations." So with these remarks, let me start my scientific presentation today. I'm giving you a timeline of academic life. I told you I spent about 10 years at All India Institute of Medical Sciences. I did my endocrine fellowship at University of Alabama in Birmingham. And since 1985, I have been at University of Texas Southwestern Medical Center, where I joined as a fellow, junior faculty, and now as a professor. Very early in my fellowship career, I started working with how to improve dyslipidemias in patients with type 2 diabetes. And as you can see, and I will show you a little later, not only we worked on the concept of high monounsaturated fat diet, but we were the first ones to try statin therapy for lowering cholesterol levels in type 2 diabetes. And after a few years, when Dr. Manisha Chandalia joined me as a fellow, we reported beneficial effects of high dietary fiber intake for patients with type 2 diabetes. All these three articles, as Dr. Mishra just alluded to, were published in the New England Journal of Medicine. And you can understand how many people with diabetes are now on statin therapy. So in terms of managing dyslipidemias in diabetic patients is concerned, I'm just giving you a historical perspective here. In 2004, diabetes was recognized as a coronary heart disease risk equivalent with 10-year risk of heart disease as about 20%. And we recognize that there is high mortality with established coronary heart disease in patients with diabetes, as well as high mortality post-acute myocardial infarction. So there were some goals given for achieving the nice lipid levels. If you have extremely high risk, you go to a LDL cholesterol level below 70 or a non-HDL cholesterol below 100. With high-risk patients, which will include type 2 diabetes, the goal was given as less than 100 of LDL cholesterol and less than 130 of non-HDL cholesterol. So what is non-HDL cholesterol? Well, when patients have normal triglyceride levels, VLDL and intermediate density lipoproteins they account for about 1/5 of the cholesterol, the bad cholesterol, and LDL cholesterol is the rest. But in patients who have hypertriglyceridemia, VLDL cholesterol and IDL cholesterol, which are also atherogenic, can be much higher in them. In fact, LDL cholesterol can even be lower. So it is important in those with hypertriglyceridemia, like our patients with type 2 diabetes, to pay attention to non-HDL cholesterol, which includes VLDL, IDL, and LDL cholesterol. Now, as you know, in United States, American College of Cardiology and American Heart Association has given new guidelines, and I won't be able to present all of them, but the key thing they talk about is that all diabetic patients 40 to 75 years should be initiated on moderate or high intensity statin therapy, and there are no lipid goals given for diabetic patients. However, there are unique issues about treating dyslipidemias in type 2 diabetes. First of all, many of them have hyperglycemia, uncontrolled diabetes, and if the diabetes is really poorly controlled, you can expect them to have chylomicronemia with type 5 hyperlipoproteinemia. Some of them accumulate remnant, and you can see that here, the milky serum. Now, type 3 is accumulation of remnant lipoproteins. When patients develop diabetic nephropathy and proteinuria, that can impact their lipid levels. They can develop autonomic neuropathy with constipation and diarrhea, which can affect the choice of lipid-lowering therapy. And most interestingly, now we are even seeing diabetes in children and young adults, and it poses a question about what to do about managing lipids in these patients. You can see here, this woman has eruptive xanthomas. This gentleman had type 3 dyslipidemia with Palmer-Crease xanthomas as well as xanthomas on the elbows. So what are the goals of treatment of diabetic dyslipidemia? You prevent coronary heart disease as well as you prevent acute pancreatitis. So I have always given a stepwise approach to managing lipids in diabetes. First of all, diet, exercise, and weight loss. Then achieve good glycemic control. And then finally, you think about lipid-lowering drugs. So let's look at what are the components of nutrition which are important for managing lipids in diabetics. Clearly, saturated fats, which I'm showing here in red color, should be reduced in terms of intake. The only thing I want to say is all long-term saturates, they increase LDL cholesterol, except stearic acid, which is quickly converted to oleic acid. And the main sources of saturates are ghee, butter, palm oil. Even the medium chain saturates, which are present in coconut oil, can raise LDL cholesterol. As far as trans monounsaturates are concerned, these are the fats which are produced when you hydrogenate the fat for margarine, shortenings, and frying oils. I think these have been taken out from most of the markets, but trans monounsaturates can raise LDL cholesterol and lower HDL cholesterol. What are the good type of fatty acids? These are cis monounsaturated fatty acids or polyunsaturated fatty acids. They both reduce LDL cholesterol equally. The only thing is high intakes of polyunsaturated fats can reduce HDL cholesterol. So when I was a fellow at UT Southwestern, I compared a high carbohydrate diet, which was being recommended by the American Diabetes Association at that time, versus a high monounsaturated fat diet for 10 patients who were admitted to the clinical research center for 4 weeks each time. They took a high carbohydrate diet, then switched it over. And on the other hand, some people who started with high monounsaturated fat diet, they switched over to high carbohydrate diet in a randomized fashion. What you can see, what we observed was that the high monounsaturated fat diet caused 25% reduction in triglycerides and VLDL cholesterol, and about 11% increase in HDL cholesterol. Not only that, the glucose levels were significantly better on high monounsaturated fat diet, despite that the patients were requiring less insulin, while the energy intake, the weight remained the same. In the short-term study, we did not see any changes in glycosylated hemoglobin. So these are the sources of cis monounsaturated fat. In Indian context, it can be mustard oil, which contains erucic acid, 20 carbon, 1 double bond, or canola oil, which contains oleic acid. But all of these are rich in monounsaturated fats. In terms of polyunsaturated fat, there are some special omega-3 polyunsaturated fats, which are derived from fish oils. These are very long chain, 20 carbon, 22 carbon, 5 or 6 double bonds. And the interesting thing is they can reduce triglycerides by 30 to 50% depending upon the dose. Caution, they can raise LDL cholesterol, they can adversely affect glycemia. And another thing I would like to say is that some of the sources of omega-3, like this 18-3, they do not reduce triglyceride. Alpha-linolenic acid does not reduce triglycerides. In terms of dietary fiber, the more soluble fiber you eat, you can reduce your LDL cholesterol, and I'm giving you several sources of dietary fiber which are important in the Indian context. With Manisha Chandalia, we compared an American Diabetes Association diet with a high fiber diet. And as you can see, again, after 4 weeks or 6 weeks of each diet, plasma cholesterol was down, triglycerides were down, and VLDL cholesterol was down. We also saw improvement in mean plasma glucose and urinary glucose and a trend towards lowering of A1C. So high fiber diet can improve your cholesterol and glycemic control. Lastly, there are sources of dietary sterols. You would like to cut down cholesterol in your diet, which comes from meat, seafood, and eggs. Instead, you would like to include more phytosterols, which reduce cholesterol absorption, and they come from plant sources. Alcohol, as far as I'm concerned, it causes steatohepatitis, can raise triglycerides and result in acute pancreatitis, increase your blood pressure, contributes to obesity. So patients with type 2 diabetes should clearly avoid alcohol. So let me summarize the nutrition recommendations here. You should reduce energy intake for weight loss. You should take low saturated and trans fat diet with low cholesterol. You can substitute them with either high carbohydrate or high monounsaturated fat diet. Very important. In patients with severe hypertriglyceridemia, you want to use an extremely low fat diet with less than 15% of energy from fat. So let's go to lipid lowering drugs. I'm listing most of the drugs over here that you are very familiar with. Let's look at the statin. So in the first study, we took 16 patients with type 2 diabetes and compared lovastatin with placebo. And you can see lovastatin was able to reduce LDL cholesterol by about 35%, triglycerides reduction 25%, as well as VLDL cholesterol. It did not affect glycemic control. However, in response to a trial which was published in Lancet, I wrote an editorial which said statins for all diabetics, not so soon. So I list here for you some group of subjects which have not been studied as well. Clearly type 1 diabetics, younger patients less than 40 years, premenopausal women, and patients with type 2 diabetes from populations with low risk of heart disease like Pima Indians, Chinese, and Japanese. And some patients, particularly some 2% of Africans, can have hypobeta lipoproteinemia due to PCSK9 loss of function mutations, and it may not be a wise thing for us to start diabetics in these patients. The second subject I touched in that editorial was there are subjects with high risk of statin therapy. For example, those with age above 75 with renal insufficiency on dialysis or who have had organ transplantation, extremely hypertriglyceridemic patients on fibrates. And then there are some patients who have peculiar myotonic dystrophy and develop diabetes. Statin may not be the choice of drugs for them because of their risk of myositis. They can also cause hepatotoxicity. Recent studies show increased risk of new onset diabetes in patients being treated with statins. Sometimes you can get cognitive impairment, sleep disturbances, and teratogenicity, important for premenopausal women. Fibrates in United States, 2 fibrates are available. And in one of the very early studies, I reported effect of gemfibrozil therapy in extremely hypertriglyceridemic patients. And you can see it was, we were able to reduce triglyceride by about 50%. Gemfibrozil increases HDL cholesterol, but it can also increase LDL cholesterol. No effect on glycemic control. Fibrates also can cause myopathy, much more with gemfibrozil than with fenofibrate. However, we are learning new safety concerns with fenofibrates from controlled trials, such as cholelithiasis and leading to pancreatitis, thromboembolic disease, and it can cause increase in serum creatinine and homocysteine. Bile acid sequestrants, we should not forget about them. These are the 3 available in United States, and they can reduce LDL cholesterol by 15 to 30%. Interestingly, they can increase triglycerides, but in one of the early studies, we reported that they can improve glycemic control. Most common side effect is constipation and reduced absorption of other drugs. Nicotinic acid, it's not favored right now to use nicotinic acid, particularly for patients with type 2 diabetes. It is very good in reducing cholesterol and triglyceride levels, and it increases HDL cholesterol levels drastically, but it can cause deterioration of glycemic control. Look at the urinary glucose excretion, it went up, glycosylated hemoglobin went up, and can also cause hyperuricemia. So it is not a drug of choice for patients with type 2 diabetes. Again, ezetimibe is a weak cholesterol reducing drug. It can reduce LDL cholesterol by 15 to 20%. Mostly it is used in combination with statins, and the side effect is myopathy. The last one, as you are aware of, are 2 PCSK9 inhibitors, alirocumab and evolocumab. They are given subcutaneously every 2 weeks. They can reduce LDL cholesterol by 45 to 70%, but they don't cause any significant triglyceride lowering. Side effects are injection site reactions and nasopharyngitis. And I always tell my patients to be aware of any other weird side effects, because at the end of the day, they are antibodies. And if they develop any immune-related problem, we should all be aware of that. So my final slide, in terms of choice of lipid-lowering drugs, we should look at if our patient has high LDL cholesterol or high non-HDL cholesterol levels, first of all. If triglycerides are normal, you can choose statins, bile acid sequestrants, ezetimibe, PCSK9 inhibitors, or combination therapy. If the triglycerides are extremely high, choice of therapy is fibrates or fish oil. You can combine them with statins, avoid nicotinic acid. If they are borderline, you can either choose statins or fibrates. Let me thank my mentor at UT Southwestern, Dr. Scott Grundy, who have been very kind to allow me freedom to do these studies, and also have always helped me in going ahead with my career. Also, I'd like to thank my family. These are my daughters, Ushma and Ashima, and my wife, Sandeep, on a beach, and they have been very kind to allow me time so that I could pursue this passion in my career and in my scientific pursuit of novel therapies. Thank you very much.
Abhimanyu, absolutely wonderful lecture, very clear. That's what we wanted. That's what all of us wanted. And I'm really thankful to you for sparing time for us. And I know Dr. Scott Grundy, having worked there with you, and he's such a great person, great scientist. And the whole UT Southwestern, your department was wonderful when I worked there. Uh, and I'm so glad that you are continuing with your academic pursuit and going higher and higher. So thanks, Abhimanyu. Once again, we will not take any questions for oration. And you were the fittest person for Ahuja Bajaj oration, and we are really grateful. Thank you.
Thank you, Anu.
We go on with the next part of the program, and I hand over mic to Dr. Ritesh Gupta for the next scientific quiz, which is next on the program.
Thank you, sir. We have a quiz now. In fact, we have quiz in two parts. We have quiz today, and we also have a quiz tomorrow. So let me first tell you all that you have to join the quiz separately. So there is a icon with a light bulb name and phone number. And then you can.
Ritesh, can you repeat that again, because your voice was cracking? Please give instructions once again.
Yeah. So there is a icon with a light bulb at the bottom left of all the attendees, and one can click on that and enter the name and phone number. And after that, you are free to join the quiz. There will be questions appearing on the screen with 4 options, and you have to click on the right option, which you think is right, and do it fast, because the one fastest response, the person with the one fastest response will get the prize. And there are 3 questions, so we'll have some time for you to register yourself, and then we'll start the quiz.
I encourage everyone to enter the quiz. We have got cash prizes for 3 winners today.
Hitesh, give some more time.
Yeah. So we'll wait for some time.
Dr. Ritesh, I hope the questions are easy.
Yeah, so today's quiz is primarily on nutrition. So there are 3 questions on nutrition, and yeah, I'm sure there will be people who will be able to answer it.
I think nutritionists should enter more.
Yes.
So Eliza is here, and I can see Dimple. There are doctors here. Ritesh, wait for 2 minutes and then we are good to go.
Yeah.
I think this is fine then.
Yeah.
Oh, there's one more.
Yeah.
Give another 30 seconds.
Sure.
I think you're good to go.
Yeah, we can start now. Okay, so we'll start with the quiz now.
Himanshu, please display.
Yeah, this is the first question. So which of the following is not rich in omega-3 fatty acids? And your options are here: chia seeds, flaxseed, mustard, and seaweed.
Not rich.
Not rich in omega-3 fatty acids.
You have 3 seconds left.
Yeah, so mustard was the correct answer, and 3 people have answered correct. That is good. So we go on to the next question. How many calories are present in 10 almonds? And your options are 150, 70, 20, and 40.
Last 3 seconds.
Yeah. So a large number of people have answered correctly. Which brings us to the next question, the last question today. Which nutrient forms the bulk of avocado? Protein, ascorbic acid, monounsaturated fatty acid, or fructose? Yeah, so the correct answer is monounsaturated fatty acid, and you heard an excellent talk by Dr. Garg, and many of you have answered correctly. So this brings us to the end of the quiz. We'll announce the winners at the end of today's sessions at around 9 o'clock, and all the best to all the winners. Thank you.
Ritesh, your questions were too easy. Everybody answered almost.
Yeah, I could see that. Yeah.
Okay. Yeah, move on, please.
We go on to the next session, and it's my pleasure to invite Dr. Purvi Chawla from Mumbai. She's a consultant diabetologist and director of clinical research, Dina Diabetes Care and Mumbai Diabetes Research Center, Mumbai. And she'll be delivering her talk on the recent concepts about diet and immunity. So over to Dr. Purvi Chawla.
Thank you so much. At the outset, let me thank Professor Dr. Anup Mishra sir, Dr. Ritesh Gupta sir, as well as Dr. Amrita Ghosh ma'am for this wonderful invite. It's indeed an honor for me. So recent advances in diet and immunity and okay, so we've been talking about the impact of diet on human health since the Paleolithic times, and today we've reached a stage where we talk about how it's the center of illnesses like diabetes and heart disease, fueled by recent scientific advances in genomic sequences, also telling us how we can refine our recommendations further for further use. Since the Vedic times, we know that Chyawanprash, or this was a unique recipe that was conjured by the Raj Vedas for good health as well as immunity. And yet we found ourselves internationally as well as nationally talking about, during the COVID pandemic times, talking about immunity and not neglecting immunity and inflammation, and how to refine our diets for preventing coronavirus infections. So again, the human immune system is a myriad of specialized cells, communicating molecules, and functional responses acting via innate immunity and acquired immunity to form a barrier against pathogens, also identifying whether the harmful ones or not, and destroying the harmful ones, and then further remembering them to save ourselves from future attacks. Amongst the modifiable and non-modifiable factors influencing the immune response, I'm going to focus on the nutrient intake, diet, and gut microbiota. And let's remind ourselves that individuals with a weakened immune system are definitely at an increased risk of infections, and definitely these infections being far more serious in them. Again, the COVID pandemic has also taught us that those who were frail, elderly, and not having an adequate intake of micronutrients were definitely more prone to the infection and the severity of it, including fatal infections. At the outset itself, let me emphasize that there is an effect of aging on the immune system as well as of obesity. It causes a decrease in immune competence known as immunosenescence, and thus older people, especially those who are frail with inadequate intake of micronutrients, are more prone to infections and uncontrolled inflammation as well. The good part is a lot can be reversed by adequate supplementation. Similarly, obesity also diminishes the immune competence and is also a state of chronic low-grade inflammation, increasing susceptibility to a range of infections, decreasing the response to vaccination, and increasing the risk of chronic comorbid conditions, predisposing us to an exaggerated inflammatory response. There is adequate scientific evidence to show that obese are more prone to viral infections and other infections as well. But the most striking is in COVID-19, where people required more hospitalizations or mechanical ventilation, and also there were more deaths in the obese. So marching towards good immunity through diet, the immune system, let me remind you, is always active with surveillance. However, there is enhanced activity when attacked by pathogens, and this is accompanied by an increased rate of metabolism requiring energy sources, substrates for biosynthesis, and regulatory molecules. Vitamins like A, B6, B12, folate, C, D, E, and trace elements like zinc, copper, selenium, iron, amino acids, fatty acids support the immune function and reduce the risk of infections. In fact, essential nutrient deficiency or suboptimal intake of essential nutrients impairs this function and increases the susceptibility, although this can be changed through supplementation or dietary modifications. The gut microbiota also plays a very important role in educating and regulating our immune system, and gut dysbiosis is a feature of disease, including many infectious diseases. So the best diet to support the immune system is one which has a diverse and varied intake of vegetables, fruits, berries, nuts, seeds, grains, pulses, meat, eggs, dairy products, oily fish, fiber, also fermented foods that can help us achieve healthy microbiota, modulate the immune response, and protect against these infections. And the scientific evidence is galore in terms of supporting the supplementation with all these nutrients. Moving on, the WHO also issued recommendations for nutrition advice for adults during the COVID-19 outbreak. And importantly, the balanced nutrition needed in times of COVID-19 pandemic, the call for action for all nutritionists and physicians, which was led by Professor Mishra sir and team, was a very, very important initiative in this respect, which was given out last year in November, December itself. And I was a humble part of it, and I'm extremely thankful for that, sir. So they highlighted that severe COVID-19 infections may be associated with nutritional deficiencies due to a variety of reasons, but these signs should be quickly recognized and treated as well. Overall, the combination of intravenous ascorbic acid, intramuscular cholecalciferol, which is vitamin D, enteral and intramuscular vitamin E, enteral zinc sulfate, and oral and parenteral glutamine appear to be helpful in treating these patients who were hospitalized and were down with severe illness. Similarly, we have given very refined and very detailed nutritional recommendations for all category of patients, including those without any COVID-19 infection or even mild infection, in terms of macronutrients as well as micronutrients, and giving all examples of food groups, etc. In fact, for severely sick patients also, there are very detailed guidance given by this paper. And in critical illness, let's not forget that the protein intake should be increased to 1.3 grams per kg in order to supplement, so that we can save ourselves from the debilitating COVID-19. In fact, a lot of food groups and items have also been listed in this paper, and there is evidence that they have immunomodulatory effects. And for example, the broccoli or the curcumin, which is haldi, so that was emphasized in the paper as well. Internationally, this review in BMJ linking nutrition, immunity, and COVID-19 was also very comprehensive, and they have listed each and every vitamin and trace elements that are required to be supplemented in to prevent viral infections, especially COVID-19. Vitamin D, for example, has many pleiotropic actions, but supports the activity of several immune cells and also promotes the production of antimicrobial proteins, and thus is essential feature in COVID-19, and there's lots of scientific evidence supporting that. Similarly, a lot of focus has been on zinc and selenium as well, as they have antioxidant and anti-inflammatory properties, and it has been seen that low status or low levels of zinc and selenium in patients have been more prone to COVID-19 infection, as well as supplementation has definitely helped in reducing the severity of outcomes or the worst outcomes in these patients. Again, this has been highlighted, and the sources of the same are also beautifully described in this review. Just pictorially, if you look at it, this is the diet I was talking about, where there are diverse food groups, and each of these can be included beautifully in our diet. Now, let me tell you about the human gut microbiota. Highly variable microbiota is present in individuals based on age, ethnicity, our diet, and other environmental factors. Abnormal gut microbiota, termed as dysbiosis, is observed in conditions like obesity and chronic age-related conditions. Commensal bacteria are a very strong defense against pathogens with a lot of mechanistic details given here. But probiotic organisms, namely the lactobacilli and the bifidobacteria, support host immunity, and again there is definitely systematic review and meta-analysis also supporting their use. Importance of probiotics. This is again a very important feature of immunity and diet. Probiotics are nothing but exogenous, live, desirable bacteria that colonize the gut and contribute to our immune system in the gastrointestinal tract. They are commonly found in fermented foods, and that traditionally we've been eating them or including them in our diet, and they should not be avoided. The most important ones are the lactobacilli and bifidobacteria. Again, diarrheal infections as well as respiratory infections are known to be protected against by these probiotics. And in fact, there is adequate proof also in COVID-19 to tell us that those treated with those treated for COVID-19 with a drug cocktail plus antibiotics and oral probiotics found better resolution of the gastrointestinal symptoms, including respiratory disease in those taking it. So again, the role of omega-3 fatty acids cannot be more emphasized, as they have a role in oxidative stress and inflammation, particularly in ARDS in COVID-19 patients. They get metabolized to metabolites called specialized pro-resolving mediators, or the SPMs, and are known to resolve the inflammation through the NF-kappa B signaling pathway. Again, animal studies have shown their benefits, but importantly, clinical studies have shown improvement in these morbid patients in terms of ventilator-free days, new organ failure reduction, length of ICU stay reduction, and even reduced mortality in these patients. In fact, a Cochrane meta-analysis also emphasized on the same, where omega-3 fatty acids were given with other antioxidants as well. So this Philip Calder mini review in European Journal of Clinical Nutrition and the lessons for COVID-19 clearly emphasized the role of individual micronutrients, including vitamin D and zinc, but also talked about a diverse gut microbiota through dietary modulation, which in turn supports the immune system. This was a very interesting study published in July 2021, where they compared in a proof of concept study of almost 36 healthy patients, healthy adults. They compared fermented food groups with high fiber food groups, and they found that in those with fermented, who were taking fermented foods, the participants had an overall increase in microbial diversity with stronger effects from larger servings and also reduction in the inflammatory markers. The same was not seen in the high fiber group, where there was increased microbiome function, but the diversity had not increased in that short duration of 17 weeks. So thus, microbiota targeted diets can change our immune status very promisingly. Advances in nutrition, the effects of dietary patterns on biomarkers was also studied in a systematic review and meta-analysis of RCTs published just last month, October 2021. And they found amongst the 22 randomized control trials that they studied and analyzed that the Mediterranean diet appeared to be a dietary pattern that showed promising reduction in inflammatory markers like IL-6, IL-beta, and CRP as well. No other dietary
Purvi, 2 minutes to go, Purvi.
Yes, so I'm almost done. In this latest publication in Nature, just in November 2021, where they elucidated the precise molecular cascade underlying the diet, microbiota, immunity triad or interplay. Something that we've been seeing clinically, using clinically, but we did not know the molecular basis of it. And that has just recently been published in November itself. And that's the latest. Now we also know the molecular basis of it in the animal studies, and once it's ramped up to the human trials, it will provide further avenues for modulation in treating the chronic conditions. Thus, we know that the immune system closely interacts with the dietary patterns, and there is adequate evidence that the diet that positively impacts immune function contains adequate protein, particularly glutamine, arginine, and branch-age amino acids, high omega-3 versus low saturated trans fat, and omega-6 fatty acids, low refined sugars, high fiber content, and micronutrients, including all the vitamins and trace elements that I talked about. So this is my thought for the day, the healthy plate method, which all of you are already aware and are well versed with. So thank you once again for this wonderful opportunity.
Thank you, Dr. Purvi. And that was a very wonderful presentation covering a whole range of dietary approaches for immune modulation. There's one question which I have. There's a lot of talk of vitamin C. Everyone was taking vitamin C during this COVID times, though the evidence for that is rather sparse. In fact, a meta-analysis published in Diabetes and Metabolic Syndrome showed really not much benefit. In fact, the author of the meta-analysis is being awarded tomorrow as a young researcher. So what do you think? On one hand, we tell patients to eat a lot of fruits and everything, but no evidence for the role of vitamin C.
So I think this, again, let's understand that nutritional elements or nutrients are very difficult to understand in clinical trials unless the conditions are very, very controlled, like in short-term studies. So again, this is not possible very well to evaluate in a huge trial, and sometimes results may be conflicting from what we know clinically and right from tradition. So, right from grandmothers giving citrus fruits as sources of vitamin C for common cold to influenza-like illness, I think today we've come to that stage where we know that vitamin C definitely works in preventing the serious effects of COVID-19 to a great extent. And we also know the antioxidant properties of vitamin C. So clinically, we may be finding it very difficult to prove, but definitely anecdotally and otherwise we know that it definitely works.
Thank you. Thank you. I think that is the case with several nutrients that if you study a separate nutrient, it doesn't work, but the whole fruit and the whole vegetable works. And there could be many other components than vitamin C, like polyphenols and other antioxidants, which might be contributing. So thank you, Dr. Purvi. It was a pleasure.
Absolutely. Thank you, sir. And I would love to hear your thoughts as well on that.
Thank you. Thank you, Purvi. So we move on to the next lecture, and we have another very important lecture, a keynote address by Dr. Vinay Simha. And Vinay is, in fact, today is the day of UT Southwestern Medical Center at Dallas, where Dr. Abhimanyu Garg has just spoken. Dr. Vinay Sinha was there, and I was there. We had a great time in terms of academics and otherwise. But Vinay is a wonderful orator. He's a graduate of Kasturba Medical College and AIMS, fellowship training in endocrinology and nutrition at UT Southwestern Medical Center, board certified in telemedicine, endocrinology and lipidology, and currently from UT Southwestern he's moved on to Mayo Clinic, Rochester, and he's associate professor in division of endocrinology. And he continued to maintain his interest from Abhimanyu's lab of lipodystrophy to Mayo Clinic, and he's given wonderful lecture on lipid disorders, treatment of lipid disorders, and we are looking forward to his lecture today on cardiovascular risk beyond traditional lipid profile. Thank you, Vinay, for joining us.
Thank you very much, Anup. It indeed is such a great pleasure and privilege to be here. That was a very kind introduction, but probably my strongest credential is that I'm one of Dr. Garg's fellows, and I have such great pride in acknowledging that today after that great talk. So, as I said, it's a great pleasure and privilege to be speaking at this symposium, and I have been tasked with giving you a very brief overview on assessing the cardiovascular risk beyond a traditional lipid profile. The question is why? Why do we do this? And the simple fact is that unlike cardiologists, we don't see things like a sudden heart attack. I never see them. Unfortunately, this is a disease that requires years of preparation. And this is what probably keeps me up at night, both me as a patient, not a patient, but then, somebody as a potential patient and as a physician, is that this disease is cooking right under our eyes. And in some ways, it's also a good thing. It affords great opportunity for prevention. And all said and done, we have been doing reasonably well. So if you look at a bunch of studies we have had over the last couple of decades, they have all been uniformly positive and beneficial in terms of reducing overall cardiovascular risk. Nonetheless, can we do better? Oh, absolutely. If you just turn this graph around, so these are all the primary prevention trials, so you can see that there is an enormous amount of residual risk that still persists even after optimal therapy. In fact, it's well over, it's not just about the glass being half full. Well over 60-70% of the events are unfortunately not prevented despite our best efforts. So therefore, we need to do something to do better in terms of both treatment, in terms of adherence, in terms of implementation, but also in terms of identification of this risk, this residual risk. And that's what I'll be talking to you about over the next 10 minutes. Before I say anything, right off the bat, let me make this very clear. When it comes to traditional lipid profile, measurement of both total and LDL cholesterol is indeed extremely robust and is very good. So we have abundant epidemiological evidence, experimental evidence, interventions, Mendelian randomization studies, whatever. All of them have shown that total and LDL cholesterol are very good. But sometimes they alone may not be an adequate measure of atherogenic burden. Take, for instance, two patients. Both of them have the same LDL cholesterol concentration. That's the LDL-C, 130 milligrams per deciliter. But just for simplicity, so in one of them, all of this LDL cholesterol is carried by a smaller number of larger particles, whereas in the other, the same amount of cholesterol is carried in a larger number of smaller particles, smaller, denser particles. And we know that clearly the risk in this patient is way greater than the risk in this patient. So both of them have the same LDL-C, but one of them has higher number of particles and there is a difference in the size. And so it is important to look at all of these things. One other thing you can see is that each of these LDL particle has one single protein component, the ApoB, and we could look at that ApoB also as a measure of heterogeneity. So we can go beyond the LDL cholesterol concentration and look at these things. And of course, the traditional lipid profile also offers some clues in terms of the non-HDL cholesterol. We'll quickly look at the utility and the limitations of these different measures. The most important one is, of course, the LDL particle number and size, as I just alluded to. So we could count the number of LDL particles, and there are different ways of doing this. The NMR spectroscopy is probably the most commonly used one, but unfortunately, it's not the only one. There are others. And this leads to a lot of problems, mainly because there's no uniformity. So we don't know whether the results are interchangeable across the different measures. Just to keep it simple, greater the number of particles, greater the risk, and smaller the size of the particles, greater the risk. Probably, again, as a gross oversimplification, particle number is probably more significant than size in the most of the clinical studies. The other important thing to recognize is that these small, dense particles are very commonly seen in insulin-resistant states. And this probably has something to do with the fact that all of these insulin-resistant states are associated with high levels of TG-rich lipoproteins. And these TG-rich lipoproteins, the VLDL, through the CETP, will transfer some of their triglycerides to the LDL particle. And then this TG-enriched LDL particle now undergoes hydrolysis by the different lipases, leading to the generation of these small, dense LDL particles. The other important thing to recognize is this. The LDL particle number is a better marker than the LDL cholesterol concentration only in patients with high triglycerides or low HDL. We don't need to be doing this in everybody. So this is data from the Framingham Offspring study. And what I want you to recognize is this. So the yellow is LDL particles and the blue is LDL cholesterol concentration. One is LDL-P and the other is LDL-C. So if you look at people with normal triglycerides, like here 0 to 150, or all who also have normal HDL cholesterol, there is complete concordance between both the LDL-C and LDL-P. So whether you look at LDL-C or LDL-P, there is really no difference. But once you get into patients who either have low HDL cholesterol or high triglycerides, then the two curves diverge. So there is discordance then between the LDL particle numbers and the LDL cholesterol concentration. So in these people, what happens, which is a better marker? We have very good data from the MESA, which shows that if you look at the overall risk, it really doesn't matter whether you're looking at LDL-C and LDL-P. In fact, if you look at the concordant group, that's the people with normal triglycerides and HDL, it's absolutely the same. The hazards ratio is 1.27, 1.27. But when you look at the group who is discordant, there you see that the LDL cholesterol concentration does not even predict the risk. We need the LDL particle number. And therefore, as a result, if you look at large population bases, where most people actually have normal triglycerides, like such as the Framingham and the Women's Health Initiative, it did not show any superiority of LDL-P to the traditional lipid profile. And therefore, the guidelines do not even recommend checking this. But I think it may be of some utility in hypertriglyceridemic patients. The next measure is going to be apolipoprotein B, which I think is important. So there is a little bit more standardization of the ApoB measures compared to the particle numbers. And these are the different methodologies we have. The importance of this measure is that each LDL particle, and not just LDL particles. So Dr. Garg already showed you that in patients with diabetes, so there's a lot of other atherogenic particles, and we have much more atherogenic cholesterol being carried by these VLDLs and the intermediate density lipoproteins and so on. All of them has one single ApoB molecule. So measuring the ApoB provides some information on the total number of atherogenic particles which are present in plasma. The other advantage is it's not affected by TG levels, and so can be assessed in the non-fasting state. Quite simply put, greater the ApoB concentration, greater the risk. Since there is some standardization here, we can actually talk about numbers. Probably a simple measure to remember is this. If somebody has an ApoB level greater than 130 milligrams per deciliter, that corresponds to an LDL cholesterol of about 160 and a non-HDL cholesterol of 200. Clearly, they are at very high risk and need lipid-lowering therapy. A desirable ApoB is probably something like less than 90. Now, the European guidelines are, they go one step ahead. They recommend using ApoB probably as a primary measure, and not just for assessing the risk, but also to assess the intensity of treatment. And they would recommend intensification of lipid-lowering therapy at these levels in patients who are at moderate risk if the ApoB is greater than 100, high risk if it's greater than 80, very high risk if it's greater than 65. Now, it's politically incorrect to say that this is the goal. So we just simply say this is the threshold at which we would intensify lipid-lowering therapy. Again, the Framingham database did not show superiority of ApoB over traditional lipid profile in predicting risk. And these are the guidelines. So the ACC-AHA 2018 guidelines classify ApoB as a risk-enhancing factor and recommend to consider statin therapy if the level is greater than 130 milligrams per deciliter. But as I said, the European guidelines recommend that this can be used as a primary measurement for screening, diagnosis, and management, and is preferable in patients with high triglycerides and low HDL, and of course in patients with diabetes and obesity. And it's especially helpful in patients with hypertriglyceridemia. One of the places where I use it commonly is if you look at patients with primary hypertriglyceridemia, there's one of the two causes. So one is familial combined hyperlipidemia, and the other is familial hypertriglyceridemia, the so-called benign hypertriglyceridemia. Looking at ApoB levels might help us differentiate between who is at higher cardiovascular risk and needs treatment. Dr. Garg showed somebody with type 3 dyslipoproteinemia. One of the ways of establishing this diagnosis is to look at cholesterol to ApoB levels and so on. So there would be a lot of utility in measuring ApoB in patients with hypertriglyceridemia. The next thing that is probably getting into vogue is measuring remnant lipoprotein cholesterol concentration. So new assays have been developed, which basically there's immunoprecipitation of the LDL and the HDL particles, and then total cholesterol minus the LDL and HDL cholesterol is remnant lipoprotein cholesterol. Essentially what we have is once the TG-rich particles undergo the initial hydrolysis, so we get these remnants. And so these are quite heterogenic, and we can measure the cholesterol in them. And the reason why we should probably do is many studies have shown a strong association with coronary artery disease. In fact, there's also Mendelian randomization studies which have shown that patients with elevated remnant lipoprotein cholesterol, which by the way correlates very well with non-fasting triglycerides, they are at higher cardiovascular risk. There's also data showing that in patients who are well treated with statins, higher levels of remnant lipoprotein cholesterol, they predict risk and survival. So this is probably a useful measure. But again, this is not uniform. So as of now, there is no clear evidence showing additional benefit over a traditional lipid profile and is not recommended for risk assessment or treatment. Now, I've also included non-HDL cholesterol. Now, this is really not anything advanced. I think this should really be mainstream. There are so many advantages. It's quite simple. It's inexpensive. It is standardized. It can be assessed in the non-fasting state. And there is tons of evidence showing that it is superior to LDL cholesterol and comparable to ApoB in assessing both the baseline and the on-treatment ASCVD risk. This is data from the Framingham study again. So as you can see, across any particular LDL cholesterol, increasing levels of HDL cholesterol, they will signify greater risk. Whereas across any particular level of non-HDL cholesterol, the LDL cholesterol is really useless. So it doesn't really tell you. So if there's one measure that you want to utilize, then the non-HDL cholesterol should probably be something that can be easily applied even today in clinical practice. So it is recommended for both screening and treatment. The next thing is lipoprotein little a. We can spend a whole day just talking about it, so I won't tell you anything too much about it, just that, again, there are different ways of measuring this. And this is basically the LDL particle, which is complexed with the apolipoprotein A. And this is elevated in about 20% of the population and has a strong association with coronary artery disease and other atherosclerotic cardiovascular disease. The guidelines recognize this as a risk enhancer in those at intermediate risk. Some other experts actually recommend that everybody should at least once in their lifetime get an lipoprotein A measured, especially so in patients where we suspect primary hypercholesterolemia and who have premature coronary artery disease family history, mainly because perhaps there is some benefit to treating them with a PCSK9 inhibitor in addition to statins. Finally, a few brief comments about coronary artery calcium score. The point I want to make is this. This is not something that should be used in everybody. It's only recommended in those at intermediate risk to decide on the need for statin therapy. And why do I say that? So this is data that again comes from the MESA study. So they had CAC scores at baseline, and then they had the event rates. They followed them up, and then these are the CHD rates. What they looked at was this. How did the CAC score help differentiate the risk compared to the baseline estimated risk? Don't go by the numbers, it's too complicated. You can just look at the color. So this is the green and green. So if you're green, then the estimated risk was less than 5%. And this is at the end of the study. So what were the actual event rates? So again, if this is again green, then it's less than 5%. So and this would be high, greater than 20%. So at these extremes, that is people who are at very low risk, where the a priori estimated risk was less than 5%, or who are at very high risk, greater than 20%, getting a CAC score was useless because you still ended up with the same colors. The only people where it made a difference were those here at the intermediate risk, between 5 to 20%. In these people, if you found a CAC score that was 0, then you were able to reclassify them. See how the color now changes back to green. So the only utility of obtaining coronary artery calcium score is to reclassify people who are at intermediate risk. In them, if we find a CAC score that is 0, probably we can safely say that their risk of a heart disease, at least over the next 5 years, it's never going to be 0, of course. You can still see it is 1.5 or 4.6. So it is low enough that it might be reasonable to withhold statin therapy at that time. So coming to the conclusions, as regards advanced lipoprotein testing, we have multiple novel non-traditional biomarkers which have been identified. But here's the point, they only minimally enhance risk prediction. So here's a paper from 2006, and I don't expect you to look at anything. You can't read all of this. But the reason why I put up this table is just look at the number of these different non-traditional risk factors which were identified in 2006. So now we probably have an even longer list. But then if you look at the ROC curves, you will see that the area under the curve is almost the same. This is one of them is with, I actually have the C statistic. You can look at the C statistic, which is a measure of the additional benefit that adding these biomarkers give over a traditional lipid profile. And this is almost nothing, 0.76 and 0.77. So there is not too much that we gain when we just look at all of these traditional risk factors. So we need to be judicious in using them. And probably their greatest utility is as risk enhancers to guide treatment decision in those who are at intermediate risk. And here, I think their greatest benefit is in looking at the risk in patients with hypertriglyceridemia who have low LDL cholesterol. So many of these patients with this characteristic diabetic dyslipidemia have a seemingly low LDL cholesterol. And again, Dr. Garg showed you how the majority of the atherogenic lipoproteins are probably in the intermediate density and the VLDL. And one way of measuring that is probably the non-HDL cholesterol and the ApoB. So again, I didn't go into the individual studies. So there are some which probably suggest ApoB may be a better marker than non-HDL cholesterol. And finally, there is very limited utility of advanced lipoprotein testing in patients with severe hypercholesterolemia. I often see that. So patient comes with FH and they unnecessarily get NMR, lipoprotein profile. People want to look for large fluffy particles and so on. That's completely useless. The only thing which may be of benefit in patients with severe hypercholesterolemia is to measure the lipoprotein little a, mainly because it might help us. Now we may have a new therapy soon. But as of now, maybe considering a PCSK9 inhibitor, which causes about a 30% reduction in LP little a, may be a reasonable choice in these patients. Thank you very much.
Thank you, Vinay. That's wonderful lecture. And I had one question, but before that, I must tell you that in India, the package, so-called package test, there are plenty of package tests, and they all include lipoprotein little a, homocysteine, and ApoB. So this is the routine type of thing, but we, of course, we don't want to encourage that. Just let me know that as far as ApoB is concerned, and that has been found to be of use, in routine practice, do we order it or do we don't order it in routine practice?
Well, if cost is not an issue, certainly yes, I think you can do it. The utility would be, I do think that in the Indian context where many patients have hypertriglyceridemia, I do think that ApoB is useful. The way somebody put it to me is this: it's a good idea to wash all the fruits, but you don't really need to wash the bananas. You're going to peel it off. But no harm in doing that still. So if you can get it as part of a package without paying extra, oh yes, certainly, why not? I think you could do it. And again, LP little a also. I know we really, Dr. Garg actually said, we don't know what to do with it as of yet. The only times I do measure LP little a is patients who are having recurrent events despite good control of traditional risk factors. And these are the only people at Mayo Clinic who still get LDL FRSs. Nobody else gets LDL FRSs now, but then these patients with high LP little a. So there is an antisense oligonucleotide which has been developed for the LP little a, and I think we should, I'm looking forward to that. In the Indian context, I know that there is a high prevalence of LP little a, and that causes both thromboembolic disease and atherosclerotic cardiovascular disease. So yes, the problem is we don't know what to do in the vast majority of people. Yes.
Thank you, Vinay, for again very lucid, wonderful lecture, and we have learned a lot. So thank you for taking your time and giving lecture for us. Thank you.
Thank you. My pleasure. Thank you very much.
So we move on to the last lecture, and that is me. I'm the last batsman, and my topic is regarding a drug which is dapagliflozin. Just give me a minute to have a pointer option. Okay, pointer option. Okay. So I'll make a case that benefits of dapagliflozin apply to majority of Indians with diabetes. However, in this particular lecture, I will only discuss a part of effects of dapagliflozin, and that is on weight, liver fat, and pancreatic fat, because that's where we have done research recently. And the second part, we will deal with its effect on CKD. There's the conflict of interest. And here is my research team who have been with me for the last 15 years and have wonderfully supported my research. Now, part one, weight reduction with dapagliflozin is important for liver fat, pancreatic fat, and insulin sensitivity. I'll show you some data. But before that, let's understand how the physiology of fat deposition in Indians work. Now, this is the non-morbid phenotype here. If you take excess energy here, it gets deposited in the superficial or sometimes deep adipose tissue. There are two layers of subcutaneous adipose tissue, superficial and deep, and causes adipocyte hyperplasia. But doesn't get deposited too much in visceral adipose tissue and not much in the liver. So there is hardly any change in cardiometabolic factor. Then this kind of phenotype is many people have, but very few people have in India. Now, what Indian phenotype is, you see here, this is the subcutaneous adipose tissue, thick. And this is what I will explain to you next. If you take excess energy, in Indian phenotype, it gets deposited in the superficial, but more importantly, in deep subcutaneous adipose tissue. Now, remember, while we talk a lot about intra-abdominal adipose tissue, it is the subcutaneous adipose tissue which is very large in volume, 3 times larger than intra-abdominal, and which can throw out a lot more free fatty acid. Right? This kind of thing causes adipocyte hypertrophy and which decreases adiponectin. There's a whole lot of free fatty acid here which gets deposited into liver and also pancreas, and it causes hyperinsulinemia, increased glucose, decreased HDL, high triglyceride. So this is upfront for you so that you understand where we are going in the subsequent slide. Now, liver steatosis matters for diabetes. We have heard about fatty liver for a long time now, but we are beginning to understand that this is something which is possibly beginning, middle, and end as far as diabetes is concerned. So if you see, this is the normal liver, 11 centimeter. And then this is the grade 3 fatty liver, huge liver, 22.8 centimeter. And earlier we have worked on this, and using ultrasound, we measured liver span. You can see the liver span here. And cutoff for lending high diabetes risk was 15.6. Look at this liver span, which is 22.8. And the liver span cutoff for lending liver fibrosis risk also we have worked out in the recent publication, which is 15.6. So same, both are same. And in this particular publication, we say we don't just have fatty liver. We have a bad fatty liver. We have fibrosis of the liver. And around 20% of our diabetic patients have liver fibrosis as estimated by FibroScan. So the diabetes perhaps starts with the fatty liver. It causes further problems with the fibrosis and then cirrhosis of the liver. And there are a couple of studies which show that if you have fatty liver, the treatment becomes more difficult. And to correct blood glucose and other metabolic problems becomes more difficult. But not much is known about pancreatic steatosis, and that's why I put the question mark here. And we have been doing some studies, and this is the pancreatic volume suggestive of fat in the pancreas in a non-obese patient with type 2 diabetes. And this is a non-obese, non-diabetic subject, and you can see difference in the pancreatic volume. So diabetic patient have fatty pancreas as well, and which may cause apoptosis of the beta cells, insulin deficiency, as well as insulin resistance. But again, the studies are not many, and we hope that many more studies in the future will actually clarify this matter, the state of fatty liver, where does it stand as far as metabolic aberrations are concerned. What is the benefit of decreasing fat in the liver and pancreas? Now, this is a 2011 study. 11 obese patients with type 2 diabetes given hypocaloric diet, followed by 148 weeks of assessment. And you can see very well and this hypocaloric diet was a lot of it was sugar. One would think that they will not give sugar, but there was a lot of sugar in this diet. And once it is given, look at the decrease in the fasting plasma glucose within first week to normal. So this reversal of diabetes within a short period of time with the hypocaloric diet. In fact, this is one of the first studies we started to trend for reversal of diabetes. But more importantly, from our purpose, look at this. Hepatic triglyceride content decreased from 12.8 to 2.9% in 8 weeks. Look at this. And the pancreatic triglyceride content decreased from 8% to 6.2%. And these authors, they thought that this is the key change which led to decrease in the blood sugar. Now, this could be debated, but well, this occurred simultaneously. And so there has to be some role of hepatic triglyceride and pancreatic triglyceride. Now, coming to the dapagliflozin, we know that it leads to weight loss, and this is the DECLARE TB trial, and you can see over a period of 48 months, there is a 1.8 kg reduction, possibly more in Indian patients. We have published that data earlier, that it may be slightly more in Indian patients. But what we are interested in is whether the dapagliflozin can cause the subcutaneous fat loss to occur, and we have told you about the subcutaneous fat accumulation, which leads to metabolic perturbations, and then liver and pancreatic fat. Now, we carried out an experiment. 30 patients of type 2 diabetes are given dapagliflozin 10 milligrams per day on the top of stable dose of metformin and sulfonylurea for a period of 120 days. Hepatic fat and pancreatic fat were evaluated by MRI-derived proton density fat fraction. Now, first, look at the subcutaneous fat. This was estimated by the skin folds at 8 sites. And all skin folds showed significant decreases. This kind of data are not available anywhere. So all skin folds, central, over the chest, back, suprascapular area, and peripheral, and thigh, everything decreased. So subcutaneous fat greatly decreased, and we have told you about subcutaneous fat as one of the factors which can cause problems. Then we go on to liver fat. And you can see that over 120 days, liver fat reduced from 15.2 to 10.1%. Now, again, this is the proton density fraction, which has been derived from the MRI. And if you compare this with LIMS study, which I showed you, so 5% here versus 10% in LIMS. So that led to reversal of diabetes. So this is significant, but perhaps it has to be more. And if you look at the pancreatic fat here, it reduced from 7.5 to 5.99%, 1.5% versus LIMS study, which showed reduction of 1.8%. So here is a drug which can mimic the calorie restriction there and may have potential for reversing diabetes. Now, this is a paper which is almost done, will be published in the next couple of months. And this will be one of its kind paper because pancreatic fat has not been evaluated by any SGLT2 inhibitor except one study in the world. Further on, in the same study, if you look at this, the fasting and postprandial C-peptide decrease, fasting insulin decreased, and postprandial. Look at the decrease in the postprandial insulin. So we are not only looking at decrease in the blood sugar, decrease in the overall weight, decrease in the liver fat, decrease in the pancreatic fat, but marked improvement in the insulin sensitivity. Let's go to the second topic of my lecture, and that is the dapagliflozin is the major advance in treatment of CKD. This is not my data. This is the data from the very famous study, which I'll show you in the next slide. But before that, the dapagliflozin can improve renal damage, has been proved in this particular study in rats. And look at this. Control patients here, diabetic patients here, and look at this. This is a massive mesangial matrix expansion. And once you give dapagliflozin back to normal, almost normal, compare these and this. And this is dapagliflozin with losartan. And then if you go to the tubulointerstitial region, again you see here, plenty of inflammation, fibrosis occurring, and with dapagliflozin, close to normal. So this is the proof in the animal study that dapagliflozin can reverse the glomerular fibrosis as well as interstitial fibrosis and inflammation. And this may work in human beings. And so DAPA-CKD trial. Now this trial was a robust trial, international multi-center trial with 386 centers in 21 countries, randomized double-blind placebo-controlled study, 4,304 patients with 68% of them were diabetic. The key points were eGFR, which is as low as 25 to 75, and UACR 200 to 5,000. And they were all on maximal tolerated labeled dose of ACE inhibitor or ARB. This is important. And one group was given dapagliflozin 10 milligram per day and other matching placebo. The classic study design. And look at this. Primary outcome was sustained more than 50% eGFR decline, ESKD, renal or cardiovascular death. And look at the 39% reduction in hazard ratio. That's wonderful. But one thing you should know that the graph between placebo and dapagliflozin did not separate up to 4 months. That means up to 4 months, there was not much of a benefit, and the benefit was only shown after that. And the graph kept on separating. So longer it is, the better it is. And the same thing was seen as far as secondary outcome was concerned, sustained more than 50% eGFR decline, ESKD, or renal death, has a ratio of 0.56, graph not separating up to 4 months. But both graphs, impressive data as far as renal outcome with dapagliflozin is concerned. And if you look at chronic dialysis, renal transplantation, renal death, again the same, a graph separating even later. Look at this, around 6 to 8 months. And this is working despite the baseline population, whether they have diabetes or not, whether they had a high UACR or not, whether they had low or high or normal eGFR. It is working all the way in all groups. So summary, the 39% risk reduction for primary composite outcome, 44% risk reduction for renal composite outcome, 29% risk reduction for composite cardiovascular death. Now, this is important because any patient with renal failure will have a high cardiovascular risk, and it is even at that time decreasing cardiovascular death and decrease in the cardiovascular mortality. So consistent treatment effect, well tolerated, and this builds on evidence from the previous trials, DECLARE trial, and other trials to show that it can reduce kidney problem, kidney dysfunction. At the same time, it can also improve the cardiovascular risk. So what is the place of treatment of dapagliflozin in diabetes treatment algorithm? We have seen this many times, but let me tell you, this we know. And tomorrow Atul Luthra will tell you more about dapagliflozin heart failure. So this works as far as hospitalization for heart failure concern high-risk patients. But this has become very clear that this is the treatment of choice as whenever diabetes with albuminuria. Now, with the diabetes and albuminuria, even with the normal blood sugar, you must use dapagliflozin and replace it. Some other drug can be replaced. And patient with low eGFR who have high cardiovascular risk, GLP-1 receptor analog or SGLT2, preferably dapagliflozin. So, final slide. Dapagliflozin is eminently suitable for Indians because of multiple benefits, some of which I have discussed, some of which I have not discussed. Younger age of onset, we know Indians have younger age of onset, longer duration of diabetes. Insulin independent action ensures sustained and long control of glycemia. Underserved and unaware population. Lower rate of hypoglycemia and decreased rate of emergency visit. And even these population can afford dapagliflozin in India because the prices have been slashed. And if you look at this, diabetes at a lower BMI, greater subcutaneous and intra-abdominal adiposity, high liver and pancreatic fat, that is the characteristic of Indian population. And so decreased fat, decreased subcutaneous fat, we have established that, decreased hepatic fat irrespective of weight loss, and decreased pancreatic fat. This is how dapagliflozin is working in Indian population. Poor beta cell function, insulin independent effects. And higher cardiovascular and renal complication. We all know that we have a high renal complication, high cardiovascular complication than other ethnic groups. So reduction in weight, blood pressure, glucose, cardiovascular benefit, decreased heart failure, and improvement in nephropathy. So thank you for listening to me this late in the night, and thank you all for participating today in this symposium. And we have half a day to go tomorrow. We had close to 1,000 people who participated there, maybe more than 1,000, Amrita?
Yeah, 1,200 logins.
1,200. And so we had a great session, great lectures, great session. And I hand over the mic to Amrita to say good night and some announcements.
At the end, I would like to thank all the audience present today and all the eminent speakers who were present still with us today. Tomorrow we will start sharp at 9 a.m. So do log in tomorrow for equally excited, equally important topics which will be covered tomorrow. To last but not the least, I have prize winners for the quiz
Just
today.
one moment, Amrita. Before that, please log in definitely, because tomorrow Honorable Justice N.V. Ramanna will be speaking from 10:30 to 10:45, and you know, he is a very learned person, very wise man, and we all will learn something from him. So please log in definitely tomorrow. Yes, Amrita.
Yeah, so we are giving one prize per question. And this was the fastest person who has answered it. For the first question, it is Dr. Abhishek Raha. Second question is Dimple Rawat. And third question is Dr. Shakti Swaroop Mishra. So congratulations to all three of you. And we will be in touch very soon for your cash prizes. Thank you so much, and a very good night to everyone. We are logging out.
Thank you, everybody. Thank you, Amrita. Thank you, Ritesh. Thank you, all of my team, for that wonderful work they have done today to ensure so much of participation and excellent lecture. Thank you to all the speakers.